as well as for the general pediatricians who how to read and what to see in the basic in the CT scan, MRI brain, and for the neonatologists who are doing and the infants who are doing the brain ultrasound, and also the very common topic is the chest X-ray. So it will be useful for all. To welcome the faculties and the delegates, I will request Professor Kalpana Dotto Madam to welcome all the delegates and faculties.
Okay. Thank you, Dr. Mihir. Very good evening to all of you. And I really happy to see this is the third webinar in the consequence of month with the very great, last two were great success. And keeping in mind that there are theories over in for the postgraduate, especially in West Bengal, in MD exam, and there is going to be how a practical exam. I don't take separately CT scan radiology classes during their tenures. Hardly we take 1 or 2 classes. So I think we have arranged for that, and it will be very helpful for them to know the basics of neuroradiology and radiology of the pulmonary, chest, X-ray chest and all. So for that, I welcome all the faculties from all over the country. We have faculties from Chandigarh, Chennai, Kolkata, Delhi, and it's really a pan-India webinar. So I welcome all on behalf of West Bengal Academy of Pediatrics, and I welcome all the delegates. And be interactive. Go on posting your chats, queries on the chat box. All the questions may not be answered in the due time, but it will be answered in the WhatsApp chat also. So you always ask questions if you have any doubt. And first session will be by Dr. Paria. And now I'll hand over this platform to our scientific chairperson, Dr. Shapan Kumar Roy, to proceed further.
Thank you, President Ma'am. And it's my sheer pleasure to welcome all the faculties and delegates. And it is from all the corner, not only from West Bengal, from India. So, Arushi Ma'am, thank you for joining. And I can see other also, and Pradeep from Raiganj Medical College. And I am thankful also to the delegates who have joined with great enthusiasm. And so I will hand over to Dr. Arundhati Banerjee to conduct the symposium today.
I think for the benefit of the audience, I would rather say Arundhati Banerjee is an assistant professor in the Department of Pediatrics Medical College, Kolkata. And she has done her MD and DM from PGI Chandigarh and Pediatric Neurology. So Arundhati, please proceed to your sessions.
Yes, so thank you, ma'am, and a very warm welcome to all the delegates. And so we would, without much ado, we would straight away go into the scientific sessions. And the first speaker for our topic will be Dr. Pradeep Paria. He is currently an assistant professor in the Department of Pediatrics from Raiganj Government Medical College. And he is also a consultant pediatric neurologist, having done his DM from in pediatric neurology from PGIMER Chandigarh. So, and his topic is identification of anatomical structures on CAT scan or CT scan brain. So over to you, Pradeep. Hope you do justice to the topic and hope we can help the JRs. Thank you.
And also maintain the time also.
Yeah, and try to maintain the time also.
Before Pradeep start, can we request Arushi ma'am to say a few words, because she may not be present the whole day because before Pradeep start. Yeah.
So you just say a few words about the Dr. Arushi, and she will say, then we'll call her to say a few words. Dr.
Thank you, ma'am. Thank you, Dr. Mihir. I hope I'm audible.
Yes, you are audible.
I think it's a very nice initiative, ma'am, and congratulations to your team. And I think that I'm really impressed by the strength of the participants. The numbers are 150 above and still counting. So I'm sure these sessions are already a hit, and I hope for these 2 days we do justice to your program. And again, many congratulations, you're a wonderful team, and I think this is a very wonderful initiative. And thank you for having us all on board. Thank you, ma'am. Thank you, sir.
Thank you. And for your information, in the first session, we had more than 300 delegates.
Today also the 270 registration already done. They will be joined very soon. Yes.
Oh, very good.
Over to you, Pradeep.
Good evening. Am I audible? Hello.
Yes,
Yes, yes,
yes,
you're
yes.
audible.
Is my screen is visible now?
Yes,
Yes,
it's
we
visible.
both visible.
Good evening to all of you, especially me, sir, Kalpana ma'am, and Sapun sir. Today, my privilege to present in this platform the basic anatomy of the city brain. I will go through first with basic anatomy only, and the next part will be the CT scan. Some abnormalities there.
If you have any problem, you can take the help from Somnath.
Actually, it is not moving.
You quit and again join. I think.
Right click, do a right click and go to the next.
Sir, just
Right.
double click in your first screen. Just double click, sir.
Just double click.
Click here.
Okay.
Now.
Okay.
Okay,
Thank
okay.
you. And I will go through the anatomical consideration and normal structures. So first, the basic thing in main anatomical structure of the head or the skull, that is the cranium and the brain. First one is the cranium, that is the skull. The skull consists of two main parts, that the calvaria and the base of the skull. Calvaria is the dome-like upper portion of the skull. It consists of the upper parts of four bones: the frontal bone, the two paired parietal bone, and in posterior portion, the occipital bone. These bones are connected by three sutures: the sagittal suture between the two parietal bones, and the coronal suture between the frontal and parietal bone, and the lambdoid suture between the parietal and occipital bone. The calvaria lodges the two cerebral hemisphere, thalamus, and surrounding structure. Next, the base of the skull. The floor of the cranial cavity consists of three fossa: the anterior cranial fossa, the medial cranial fossa, and the posterior cranial fossa. The anterior cranial fossa, its floor is formed by the orbital plate of the frontal bone, cubiform plate of the ethmoid bone, and lesser ring of the sphenoid bone. It lodges the frontal lobe of the cerebral hemisphere. In medial cranial fossa, it is formed by the greater ring of the sphenoid bone and petrous part of the temporal bone. It lodges the pituitary gland and the temporal lobe of the cerebral hemisphere. And in the posterior cranial fossa, it is formed by the petrous part of the temporal bone and occipital bone behind. It lodges the cerebellum, pons, midbrain, and fourth ventricle. Next, that is the brain. The brain consists of four main structures. We already know: the cerebrum, the thalamus, that is the diencephalon and surrounding structure, brainstem, and the cerebellum. First one is the cerebrum. It consists of two cerebral hemispheres, right and left. The two hemispheres are separated in the upper part of the medial surface by the falx cerebri, and in the lower part by the interhemispheric fissure and corpus callosum. Each cerebral hemisphere is formed by four lobes, that is the frontal, parietal, occipital, and temporal. Frontal or parietal are separated by the central sulcus, and temporal and frontal lobe are separated by the Sylvian fissure, and the temporal, occipital, and parietal lobe are separated by the parieto-occipital. So, parieto-occipital. Each hemisphere is formed of an outer part, that is the gray matter, and the inner part, that is the white matter. The gray matter is formed of the nerve cells, and when the white matter is formed by the nerve fibers. Next one is the thalamus and the basal ganglia. That is the thalamus and the related structure. The thalamus consists of two oval bodies separated by the cavity of the third ventricle. It lies below the corpus callosum. It lies below the corpus callosum and above the midbrain. The fornix lies above it, and hypothalamus below it and anterior to the midbrain. The pituitary gland below the hypothalamus and connected to by the infundibulum, and the pineal body lies behind the thalamus. The internal capsule and the basal ganglia, that is the caudate nucleus, lentiform nucleus, lie anterior and lateral to the thalamus. The internal capsule has anterior and posterior limb. The anterior limb lies between the head of the caudate nucleus and the lentiform nucleus, while the posterior limb lies between the thalamus and the lentiform nucleus. And the floor of the foreventricle is made by the horizontal part of the hypothalamus. Next one is the brain stem. It consists of three parts: the midbrain, the pons, and the medulla. The midbrain is the uppermost and the shortest part of the brainstem, encircled by the tentorial notch of the tentorium cerebelli. It is related above to the thalami and is separated from each thalami by the subthalamus. The cerebral aqueduct of the midbrain connects, that is the cerebral aqueduct that connects the third ventricle and the fourth ventricle. The third and fourth cranial nerves arise from the midbrain. And next is the pons. That is the pons. Pons is the middle part of the brainstem, and it lies between the basilar part of the occipital, that is the basilar part of the occipital bone anteriorly, and the cavity of the, that is the cavity of the fourth ventricle posteriorly. The fifth, sixth, seventh, and the eighth cranial nerves arise from it. Next part is the medulla, is the lower part of the brainstem. Its upper part lies anterior to the fourth ventricle, and its lower part is traversed by the central canal. The last four cranial nerves, that is 19, 11, 12, arise from this medulla. Next part is the cerebellum. It consists of two cerebral hemispheres, right and left, connected together by the median part called the vermis. Each cerebellar hemisphere has a circumscribed mass in its inferior surface, that is known as the cerebellar tonsil. The cerebellum lies in the posterior cranial fossa, undercovered by the tentorium cerebelli. The cerebellum is connected to the brainstem by three parts of the cerebellar peduncle. That is the superior, middle, and inferior cerebellar peduncle. The superior cerebellar peduncle connects to the midbrain, middle cerebral peduncle connects to the pons, and inferior cerebral peduncle connects to the medulla. Next one is the in anatomy, that is the CSF spaces. The cerebrospinal fluid is excreted by the choroid plexus, that is secreted by the ventricular system. It circulates from the ventricular system to the subarachnoid space to be drained into the superior sagittal sinus through the arachnoid granulation. The ventricular system consists of four ventricles, two lateral and third ventricle and fourth ventricle. The CSF from the lateral ventricle passes to third ventricle to through the foramen of Monroe, and from the third ventricle to the fourth ventricle through the cerebral aqueduct. It leaves the fourth ventricle to enter the subarachnoid space through the median foramen and the foramen and the two lateral foramina. Next one is the subarachnoid cisterns. The subarachnoid cisterns are wide areas in the subarachnoid space that can be visualized by the CT scan. There are five main cisterns. That is the suprasellar cistern above the sella turcica, interpeduncular cistern, that is the anterior to the midbrain, the quadrigeminal cistern, that is the posterior to the midbrain, the pontine cistern, that is anterior to the pons, and the cisterna magna, that is the between cerebellum and the lower medulla. Next one, just a glimpse of the vascular supply of the brain. The brainstem and cerebellum are supplied by the anterior arteries arising from the paired internal carotid artery, that is the anterior circulation, and the paired vertebral arteries, that is the posterior circulation. Each internal carotid artery gives rise to middle cerebral artery and anterior cerebral artery that supplies the frontal, parietal, and superior and lateral temporal lobe. And the in posterior circulation, the vertebral artery arises from the subclavian to join to form the basilar at around the level of the pontomedullary junction, and end by giving up the posterior cerebral artery that supplies the occipital lobe and inferomedial temporal lobe. Next one is the CT head. That is the radiological diagnosis of for radiological diagnosis of the intracranial pathology. Actually, CT of the head has become the integral part in the radiological diagnosis of the intracranial pathology. The technique was developed and introduced into the clinical use by the British physicist Hounsfield in 1972. For this, he was awarded Nobel Prize in 1979. Some technical aspects, that is the sedation. It is important to sedate the patient prior to the technique to prevent the head movement. One of the several available drugs can be used like chloral hydrate, diazepam, midazolam, and ketamine. Sedation is contraindicated or should be made with caution in patient with potential airway obstruction, respiratory failure, several renal and hepatic failure. Next one is the angle of cuts. Most brain scans are performed with the plane of section angle to 10 to 15 degree to the orbitometal line, which extend from the lateral canthi of the orbit to the external auditory canal. This angulation is important because it provides better visualization of the posterior fossa, that is the brainstem and cerebellum. Next one is the thickness. Actually, in children, a slice thickness of 8 to 10 millimeter is used for section above the posterior fossa, and 5 millimeter slice thickness is used for the posterior fossa. And last one is the number of cuts. 12 to 14 cuts are usually taken serially from below upwards, that is starting from the base and rising to the brainstem, thalamus, and cerebral cortex. The first picture of the CT film is called the scanogram. This is the scanogram, and it demonstrates the angle, the thickness, and the number of cuts. Next one is the type of CT scan. The one is plain CT and another is contrast enhanced CT. Plain CT is the initial procedure of all patients and is frequently the only required one. Several lesions like hemorrhages, infarction, calcification, and ventricular dilatation can be clearly demonstrated with plain CT. And in contrast enhanced CT, it is usually to inspect the plain CT first and if necessary to proceed to the IV injection. Contrast enhanced CT is useful for many reasons, like tumors with the abnormal vasculature are enhanced and better visualized with contrast enhancement. If there is aneurysm or angioma, or they are also enhanced. If there is vascular structure, if there is the to differentiate between the gray and white matter in cases of brain edema, etc. Next one is the level of the CT scan. Actually, because of the easy visualization of the lateral ventricle and third ventricle, it is common to classify the cuts into 4 levels: supraventricular, ventricular, infraventricular, and at the base of the skull. More precisely, 8 levels should be identified because the anatomical structure and the radiological findings are different at these levels. Some overlap between these levels may occur depending on the direction of the cuts. Then the level 1, the first cut, the level of the above the level of the lateral ventricle. Second one is at the level of the bodies of the lateral ventricle. Third, at the level of the horns of the lateral ventricle. Fourth, at the level of the third ventricle. Fifth, in midbrain. Sixth, in pons. Seventh, in medulla, and at the base of the skull. I will repeat. First one for above the level of the lateral ventricle. Second, for bodies of the lateral ventricle. Third, horns of the lateral ventricle. Fourth, at the level of the third ventricle. Fifth, midbrain. Sixth, pons. Seventh, medulla, and eighth is the base of the skull. Next, that is above the level of the ventricle. What we can see at the above the level of the lateral ventricle, this level demonstrates the cerebral hemisphere and the falx cerebri. Important radiological findings are this is the falx cerebri. It appears as a dense sagittal line separating the 2 cerebral hemispheres. The thickened, that is the falx cerebri, the thickened anterior and also the posterior anterior. The thickened anterior and posterior end of the line represents the cross-sectional views of the anterior and posterior part of the superior sagittal sinus. That is the falx cerebri, and that is the superior sagittal sinus, that is the anterior and posterior thickened portion. Next one is the gray matter and white matter. The central white matter of cerebral hemisphere is less opaque and appears darker than the peripheral gray matter. That is the white matter, and the periphery is the gray matter. The line of demarcation between them is known as the gray-white junction, which is more apparent with contrast-enhanced CT. This gray-white interference is exaggerated in degenerative disease of the white matter and is diminished or lost in cases of brain edema. Third one is sulci, that is the deeper portion, that is the groove. Groove and gyri is the fold. That is the sulci, and gyri is this fold is gyri, and this groove is sulci. The sulci and gyri of cerebral hemisphere are apparent because the CSF in the sulci is less dense than the brain tissue, and this makes the sulci darker than the gyri. That is the gyri, and that is the sulci. I will also give some schematic diagram in side by side. Next one is cerebral hemisphere. That is the total is the cerebral hemisphere that is in midline, that is divided by the falx cerebri. In cerebral hemisphere, that is the frontal lobe, that is in middle, that is the parietal lobe, and in the posterior portion, that is the occipital lobe. And in periphery, that is the cranial bones. I want to repeat, that is the falx cerebri, that is the cerebral hemisphere, that is the frontal lobe, parietal lobe, and it is the occipital lobe. That is the sulci, that is the gyri, and that is the white matter, and in the periphery, that is the gray matter, and in between, that is the gray-white junction. Next one. Next one, at the bodies of the lateral ventricle. That at the level of the at the body of the lateral ventricle, this level demonstrate the bodies of the lateral ventricle, corpus callosum, body of the caudate nucleus, and cerebral hemisphere. Important radiological findings are interhemispheric fissure. That is the interhemispheric fissure. That is the interhemispheric fissure. It is the dense sagittal lines separating the two frontal lobes anteriorly and the occipital lobe posteriorly. And next one is the corpus callosum. It is a midline structure between the bodies of the two lateral ventricle. That is the corpus callosum. It is the bodies of the lateral ventricle. They appear as two dark curved bands separated by the corpus callosum. And the radiopaque posterior margin of the each lateral ventricle represents the forehead plexus. That is not seen on this slide. And that is the bodies of the caudate nucleus. That is, they represent the just lateral to the lateral ventricle. That is the body of the caudate nucleus. And in cerebral hemisphere, that is the frontal lobe, that is the parietal lobe, and that is the occipital lobe. Next. It is the horns of the lateral ventricle. In this section, the level demonstrates the frontal and occipital horn of the lateral ventricle, thalamus, basal ganglia, capsule are shown at this level. Important radiological findings are that is the horns of the lateral ventricle. That is the lateral ventricle, that is the horns of the lateral ventricle. These two are the frontal horns. And these is the occipital horn in behind, and in between that, the dividing marker is the septum pellucidum. The frontal horns appear to dark bonds anteriorly separated with the septum pellucidum. Next, that is the thalamus. The two thalami appear as two large oval bodies just anterior to the occipital horn of the lateral ventricle. That is the basal ganglia. The head of the caudate nucleus just lies just posterolateral to the frontal horn of the lateral ventricle, and the lentiform nucleus, that is the lentiform nucleus, lies lateral to the thalamus and separated from it by that is the internal capsule. That darker portion is the internal capsule. That is the caudate nucleus, that is the thalamus, that is the lentiform nucleus, and in between that curve-shaped structure is the internal capsule. Internal capsule is the appears as a thin curved dark line between the lentiform nucleus laterally, and thalamus and head of the cortex nucleus medial. And in this portion, cerebral hemisphere is the frontal lobe, parietal lobe, and the occipital lobe. Next one is the level of the third ventricle. In this section, this is the third ventricle, the slit-like appearance. The centrally located midline dark band between the two thalami is the third ventricle. That is the thalamus. I already told you. That is the frontal horn of the lateral ventricle. That is the basal ganglia, consists of caudate nucleus. That is the lentiform nucleus, and in between the internal capsule. And there may be pineal body. It may appear as a glandular radiopaque body directly posterior to the third ventricle in this position only. There may be pineal body. I have already shown in the schematic diagram. That is the pineal body, and behind the third ventricle, this is that darker portion is the quadrigeminal cistern. This is the quadrigeminal cistern. It has a dark curved band just behind the pineal body, and their appearance of this one is the Sylvian fissure. They usually appear at this level. Presence of Sylvian fissure indicates that the lateral lobe is the temporal lobe. That is the frontal, that is the temporal, and that in behind the occipital lobe. That is not the parietal lobe. If the Sylvian fissure appears, that the lateral lobe is the temporal lobe. Next one is at the level of the midbrain. At this level, this is the midbrain. It appears as a central apple-shaped body between the that is the interpeduncular cistern in front of the midbrain. I already told in the anatomy that the interpeduncular cistern in front of the midbrain, and quadrigeminal cistern is behind the midbrain. This apple-shaped structure is the midbrain, and it lies between the interpeduncular cistern anteriorly and quadrigeminal cistern posteriorly. And that is the circle of Willis also. Circle of Willis, it surrounds the interpeduncular and suprasellar cistern. The anterior, middle, and posterior cerebral arteries are visualized in these film by contrast media. Next one is the at the level of the pons. At the level of the pons, that is the pons, it appears as a central body lying between that is the pontine cistern anteriorly and the fourth ventricle posteriorly. This is the pons. In front is the pontine cistern, and behind is the fourth ventricle. Fourth ventricle, it appears behind the pons as a kidney-shaped and dark shadow with the concave surface posteriorly. And when the pons appears, the posterior region is the cerebellum, not the occipital lobe. That is the tentorium cerebelli. That is the petrous part of the temporal bone, and that is the tentorium cerebelli. When the tentorium cerebelli appears, and as the tentorium cerebelli attached to the petrous part of the temporal bone, the appearance of this bone indicates the posterior part is the cerebellum, not the occipital lobe. The fourth ventricle appears anterior to the cerebellum. Next, that is the temporal lobe. That is the temporal lobe in the middle cranial fossa. That is the temporal lobe. The right and left temporal lobe of the cerebral hemisphere appear in the middle cranial fossa, and that is the orbital roof of the orbital roof. That is the orbital roof, and that darker portion is the olfactory valve. That is the orbital roof, and the darker portion is the olfactory valve. Next one is at the level of the medulla. At the level of the medulla, this level demonstrates the orbit, that is the orbit, that is the nasal cavity, nasal sinuses anteriorly, that is the temporal lobe in middle cranial fossa, and that is the cerebellum. And this is the fourth ventricle, and in front of it is the medulla. It is the orbit, that is the nasal cavity, that is the temporal lobe in the middle cranial fossa, that is the cerebellum, that is the fourth ventricle, and in front of it is the medulla. And the last one is at the level of the base of the skull. Actually, this level demonstrate the lower part of the medulla, that is the lower part of the medulla, that and the central canal, that is the central canal. It is the medulla, and this is the central canal. And these are the ethmoid and air sinuses. These are the ethmoid air sinuses. So in this film. Next is the remarks for the localization. The glimpse of this presentation is that if supraventricular cord is there, the brain is mainly the parietal lobe. If the sylvian fissure is absent, the lateral lobe are the parietal. Once it appears, the lateral lobe are the temporal. If the petrous part of the temporal bone appears, the lateral part are the temporal lobe and not the parietal lobe, while the posterior part is the cerebellum and not the occipital lobe. If the fourth ventricle appears, the structure in front of it is the pons in higher cards or in the medulla in lower cards. And it is important to re-emphasize that the angulation of cards can considerably affect the localization of the anatomical structure. Thank you. With this, I have completed my presentation.
Dr. Arundhati?
Yes. So thank you, Pradeep, for a wonderful session and very lucidly how you explained the anatomical details. And now, if we have any questions, then we don't find, the participants are requested to please post your questions in the chat box so that and those can be answered. And also, if you have any questions, they're not allowed, I think, sir, they are not allowed to unmute and ask.
They cannot.
They'll write,
Yes,
they'll
they
write on
cannot.
the post chat box.
Yes.
So
they can write down the questions, so we can answer in WhatsApp also.
A request from PGT about that. Again, you have to say something about the cistern.
Cisterns.
Basal
Yes.
cisterns. So the basal cisterns.
We have
If you can just explain.
actually there are many cisterns. There are 5 subarachnoid cisterns are there. The supracellular cistern, that is above the sella tarsica, the interpeduncular cistern in front of the pons, and the quadrigeminal cistern.
Can you again just share your the PPT and show in the screen?
PPT. Okay.
The slide of the cistern.
Yes.
Slide of the cistern.
Okay,
Especially the basal cistern is very important because everyone is
I am sharing.
So,
Is it visible?
yes.
Yeah.
That is the there are subarachnoid cistern are wide areas in the subarachnoid space that can be visualized by CT scan also. In MRI, that is easily visible, but in CT scan also that is also visible. There are 5 main systems. That is supracellular system, that is above the cella turcica, and that is the interpeduncular system anterior to the midbrain. I have shown that also in the slides of the CT scan. Interpeduncular system anterior to the midbrain, and quadrigeminal system. Quadrigeminal system is the posterior to the midbrain. Pontine system in front, I mean anterior to the pons, and the cisterna magna. That 5 systems are important in CT scan. That is the interpeduncular system, quadrigeminal system, pontine system, cisterna magna, and supracellular system.
Anuti, you can pick up the questions very quickly.
Yes, the questions, Pradeep, there are many others also. Like, sir, please show how the gray matter, white matter differentiation, as it matters a lot in identifying cerebral edema. So maybe if you can explain, since you have 3 minutes before our next speaker joins. So maybe if you can address this.
That is the gray matter and white matter junction. Actually, in the, look at the schematic diagram. That is the gray matter and that is the white matter. White matter is usually formed by the axon of the nerve, and gray matter is usually from the cell body. As the axon of the nerve mainly consists of myelin, that is the fat. So in CT scan, the white matter is darker than the gray matter. That is the gray matter in periphery, and in midline, that is the white matter. And in between, that is gray-white junction that can be obliterated in cases of brain edema. That is the white matter, that is the gray matter.
And then if you can kindly repeat the slide on caudate nucleus and GP, that is what they want to see on CT scan.
Caudate nucleus
and globus pallidus. So if you can just find out the section and show them once again.
Actually, internal capsule is also important clinically. So you can highlight the part of the internal capsules and that caudate nucleus.
Okay.
A bit blood supply should have been better.
That is the portion.
Yeah, this one.
Okay.
Previous one. Yeah.
Actually, my cursor is not working. Okay.
So we can see the arrow. Never mind. You can proceed with the arrow.
Arrow is
visible.
That is visible. Okay. That is the basal ganglia region. That is the caudate nucleus and lateral to the frontal of the lateral ventricle. In between, there is the internal capsule between the caudate nucleus and lentiform nucleus. In lentiform nucleus, this is the caudate nucleus, this is the lentiform nucleus, and in between this white matter is the internal capsule. Caudate nucleus, the just lateral to the frontal of the lateral ventricle, and lentiform nucleus consists of the globus pallidus and putamen. That is the caudate, that is in periphery, that is the lentiform nucleus, in between, that is the internal capsule, and below is the thalamus. Okay.
Thank you.
Thank
So
you, Pradeep.
we can move to the next.
Question left, Arundhati?
Okay, so if there are no other queries, then ma'am, can we proceed to the next speaker?
Yes, please do proceed.
Yes.
Dr. Shivan has joined.
Yes, I suppose he has joined. Shivan, Dr. Shivan, you're there?
No, I don't think, I can't see in the panelist link. He's not joined.
He told me he's joined.
He joined, then again, I think
He's not there in the panelist.
Can just call him just to.
Yeah, I just spoke to him right now. So he said he has joined. So maybe there are some glitches. Is it?
He's not here.
Just a second. I'll
Just Pradeep, in between, you can just call.
Okay. Okay.
Can we go for the second speaker? Third speaker, if second is not there, then
Actually,
third.
Actually, he's trying to join. There
Actually,
is
he
some
joined
connectivity.
initially. I saw him.
There is some connectivity problem for his side. I have just called him.
Dr. Padia, there are a lot of questions for you. If you don't mind, you can give the answer in the chat box.
Okay, sir. I will try to
Write
answer.
the answers. Sir.
Okay.
But again, you have to open up the slide because they have
I-
requested to please repeat the second, third, and fourth level.
It's not possible. It will be late. Huh?
It will be not possible, sir.
I
I
think
will
he has
try
already
to.
shown that. Pradeep has already shown that. I think he has covered. I think.
I will try to answer in chat box.
Pradeep, if there is issue in connectivity, I think we'll start with the Arundhati's talk, and then whenever he joins, he have to start. Okay.
Sir.
So I suppose he's having some glitches. I spoke to him right now. He's trying to connect. So he's from Chennai. So a long way down here. Maybe there are some glitches.
And
so
Dr.
shall we
Naveen?
wait or what shall we do?
No, I think you just call the second one, third one. The Dr. Naveen is there?
No, Dr. Naveen, I mean, there has been a slight change in the schedule.
Oh, okay.
So yeah, so it will be my talk.
Your session.
Yes.
Okay, I think you should
So
start.
shall I
And
proceed
after that,
with it? And
yes,
or
after
shall
that
I wait?
you just start. Otherwise,
Yes, Arundhati will start with your presentation.
Okay, so
Pradeep, introduce Arundhati and.
Yeah, so can I share my screen?
Oh,
I think
Shivan
has joined. I think Shivan has joined.
Yes, yes.
So I think we can have his talk first, in case he has these.
Okay.
Okay, so Shivan, are you there, Dr. Shivan?
Yes, ma'am, I'm here. Sorry for the delay.
No issue. It happens. Dr. Arundhati, go on introducing Dr. Shivan till Dr. Shivan is ready with the PPTs and share the screen. Huh?
Yes. So we have
share his screen. Ask him.
Dr. Shivan, please you can share your screen while I introduce you to the house. So we have Dr. Shivan Keshavan. He is a very promising and a young and a dynamic pediatric neurologist who has graduated and done his DM in pediatric neurology from PGIMER Chandigarh. And he is currently attached with Dr. Mehta's group hospitals in Chennai. So, and he is going to speak on the common pathologies on CAT scan brain, including traumatic brain injury. So without much wasting of time, over to you, Shivan, for a engaging talk.
Thank you, ma'am.
So you can proceed.
ma'am. Are you able to hear me and see my slides?
Yes, yes. Your slides are visible and you are audible also, Shiv.
All right. So please tell me if there is a connectivity problem, I'll rectify it. So today's session is going to be, my part is going to be on the common pediatric conditions which we encounter in day-to-day practice and the utility of CT head in that. So for the neurologist in the MRI
There's some
and
audio issue there.
Your audio is not
the
clear,
modern
Shivan.
era, the
Sivan sir, your audio is not clear. You are not audible.
80% of cases has not been very fruitful. We don't get most of our diagnosis from CT.
Your previous
But in those
was not
patients
audible.
where CT says, do it very beautifully well. Just to make a diagnosis very
Please inform.
He is again disconnected. I think there's connectivity issues there.
What he can do, Arundhati, you can suggest not to use his own video, and he can speak from a phone.
Yeah, I think he has joined back. So Shivan, can you just switch off your video, so that the connective issue gets sorted a bit. Hello, Shivan?
Ma'am, yes, I have just joined with a new connection. I think it's working fine. Just give me 5 seconds. I'll just sort it out.
Sure. Okay. In the meantime, if the participants have any question also related to the previous talk, can post their queries, because Dr. Pradeep will keep on answering. And
I am ready. So
okay,
can I continue?
Yeah, sure. If you're ready, you can.
Yeah. So yeah, sorry again for the interruption. I'll just continue. So this slide just shows that CT scan is in the MRI era. It's not very helpful in making most of the diagnosis, but in those patients where the CT scan is helpful, it's really helpful. So those are the patients and those are the cases which I'm going to discuss tonight. So what can you diagnose with a CT scan? So in acute conditions, especially in traumatic brain conditions, including fracture, bleed, hydrocephalus, so the CT scan is more than enough in making a diagnosis. In most patients, you need not have any other imaging modality apart from this. In other instances, we look for things called hyperdensity and hypodensity on the CT scan. So when you talk about the CT scan, it is about density, as Dr. Pradeep must have told you. When you read an MRI scan, it's about intensity. So this is a mnemonic which my teachers taught me and I tell my students. When you talk of hyperdensity, if you say anything which is white or bright on the CT scan, think of BCCI, that's the Board of Critical Control in India, blood clot, calcification and iodinated contrast. When you give contrast to check for meningeal enhancement or ring enhancing lesion, all these brighten up on the CT scan, then it is hypertense. When you look at hypodensities, you go for the vowels. So what are the vowels? A, E, I, O, U. So A stands for air, pneumocephalus, and E stands for edema, I for infarct. C is cyst. Cyst is circular, so O is also circular, so it is cyst. And U indicates that U is N turned upside down, so necrosis also is hypodense. So this is the mnemonic which I use for students. So before going into the actual conditions, you should know what a brain window and a bone window looks like. So if you can see in this, the left side of the panel, you can see that there is a hemorrhage here. So this will, you will be able to read this as an extradural hemorrhage. I'll tell you how to read it little later. And you can see that inside the ventricles also there is blood. So whatever white is blood, and this is the skull, which is white again, very, very white, so chalky white. So this is because of calcium in the bone. And you can see that there is a small dot, black color dot here, which resembles the air which is outside. So I'll use the pointer to show this. So if this is the blood here, this is also blood. And this is the bone. You see a small point of air, but you don't know where the air has come from. Air has to come from outside, right? But you don't see a fracture line. This is exactly why a bone window is used. So when you use a bone window, you can clearly see that at the site of this hemorrhage, you can see a fracture line, which is present in the left side, right? And you can also appreciate the soft tissue swelling here when compared to the right side, the left side, you have a lot of soft tissue swelling. This is due to the trauma sustained to that side, right? So I'll be discussing in a few slides the utility of CT in trauma. So this, as you've seen in the previous image, is a fracture sustained to the parietal bone. So you can see that the green line indicates a suture line, and the yellow arrow indicates a soft tissue hemorrhage or hematoma or soft tissue swelling, and the red line indicates a fracture line. So this is, green is a suture line and red is a fracture line. So how do you differentiate between the two? Both look very similar. This is a common query which residents and young people who are not used to read this trauma CT ask. So this is basically differentiated by certain points. So you know that a fracture is going to have an interdigitating or a zigzag pattern. If you go back to the previous slide, you can see that there is a zigzag pattern to the red line. And then this is not going to be zigzag, it's going to be very straight or linear, right? And the ends of the bone are usually sclerotic. If you can see this part very carefully, you can see that adjacent to both sides of the fracture line, you can see that the bone ends, fracture, there's a lucency, you can see that the bone ends are a little thicker. So this means that sclerosis is there. This is a natural phenomenon, whereas you don't have sclerosis in a zigzag kind of a fracture line, which denotes the fracture line rather than the suture. And you know that a skull fracture can cause suture lines, but sutures obey anatomy, just as Pradeep had taught you. And a skull fracture can be unilateral or asymmetric, but a suture is always bilateral. Again, going to this image, you can see that just opposite to this, you can see that there is a suture line here as well, but opposite to this, there is another fracture line also. So this gets confusing, but in a typical image, in most of the cases, you will have fractures only on one side of the you need not have another fracture on the contralateral side as well, right? And usually the site of the soft tissue swelling or hematoma leads you to the site of fracture. If you don't know where the fracture is, you can go and search for a hematoma. In this case, the hematoma is here. So if you search for a fracture here, you will find it in the left parietal region, right? Going to hemorrhages. So you know that there are two kinds of hemorrhages. Any hemorrhage inside the brain or within the brain is called an intraaxial hemorrhage. So inside the meninges, there is the brain and there are the ventricles with the CSF. So it can be intraaxial hemorrhages, can be intraparenchymal or intraventricular, whereas extraaxial hemorrhages can be extradural, subdural, or the subarachnoid. You know there are 3 layers of the dura. Accordingly, there are 3 potential spaces wherein the blood can get collected. So this is a cartoon which shows many kinds of hemorrhages in one single picture. So this is the image without annotation, and this is the right side, you have the image with annotation. So you can see that there is a big scalp hematoma. Again, you can have another scalp hematoma here, right? You have a subdural hematoma here, which is concave, and you have a cerebral contusion here. And these hemorrhagic events have caused the shift of midline, raising the intracranial pressure. That can be judged by seeing the falx cerebri. You can see that this is the layer of the dura which is invested between both hemispheres, is slightly shifted to the left. Similarly, the falx cerebri and the posterior aspect also shifted. And another clue to the presence of raised pressure because of this unilateral lesion is that the ventricle, the lateral horn of the frontal horn of the lateral ventricle is chinked, right? So these are all the things which you have to see in a CT scan. Once you start seeing more CT scans in trauma, you will be able to gather these findings very quickly. So how to differentiate between a subdural hemorrhage and an extradural hemorrhage? A subdural hemorrhage is crescent shape, just as I told shown in the previous picture. So you can see a subdural hemorrhage here, and because of that there is edema and ventricular chinking here. The ventricles are thinner compared to the ventricle on the right side, whereas this is a biconvex kind of a hyperdensity. This denotes extradural hemorrhage. In addition, you can see you can say that this trauma was a significant trauma, significant blow to the head, because there is subcutaneous hematoma as well. So my teacher, professor of pediatrics here, used to say that biconvex EDH looks like an idli. So this is for those who have confusion. E for idli in the crudest sense, and EDH also has this idli-like shape, right? So coming to subarachnoid hemorrhage, this is a relatively easy hemorrhage to distinguish, because you know that the pia is the only membrane which goes inside the cerebral sulci. So when the hemorrhage collects in between the arachnoid and the pia, it also follows the pia wherever it goes. So pia mater goes inside the sulci. So you can see that the bleed enters into the sulci. This is indicated by the blue arrows. These are called the Sylvian fissures. And again, the interhemispheric fissure also, it goes in between. So you can see this perpendicular line, perpendicular to the fox. So you can see that these are all the small fissures which go into the gyrae, that is which form the sulci. So blood extends into this. Hence, these are subarachnoid hemorrhages. That is how you make a diagnosis of these hemorrhages. And intraventricular hemorrhage is not very difficult to make out, but it is frequently missed. So you can see that when compared to this ventricle, you can see this ventricle has blood. When compared to this is another small spot of blood again. So this has a right more than left intraventricular hemorrhage. You should always look for this intraventricular hemorrhage in the posterior horn of the lateral ventricle, because when the patient or the child lies down, this is the dependent area. So whenever there is an intraventricular hemorrhage, it collects in the dependent area. So when the child or a patient stands, the fourth ventricle is the dependent area. But when child lies down, blood generally settles down here in the posterior part of the brain, that is a occiput in the posterior horn of the lateral ventricle. So this is where you have to look for an intraventricular hemorrhage. So this is intraparenchymal hemorrhage. So this is due to late onset hemorrhagic disease of the newborn. You can see that the child is on a ventilator, has right-sided weakness, has subcutaneous bleeds, and also has a big hemorrhage, right, on the in the left frontoparietal area. So this constitutes a intraparenchymal hemorrhage inside the brain parenchyma. So this is due to late onset hemorrhagic disease of the newborn. You can see that some amount of the hemorrhage is liquefied, and the blood has changed its consistency. This is because the hemorrhages happened multiple times. So the hemorrhages of multiple ages, that is why you have this varying appearance. Once you have a fresh hemorrhage here which is dense, you have an old hemorrhage which is liquefied, which leads to the hypodensity. Okay? So another example for an intraparenchymal hemorrhage would be an artery venous malformation. This is the story of a young boy, a 10-year-old boy, who presented with a sudden headache, seizures, and weakness of one arm. So you can see that the CT shows a big hemorrhage, which is seen in the left frontal area. You can see the hypodensity around. I told you hypodensity means it is either air, or it is edema, or it is infarct, or it is a cyst, or it is necrosis. So the structure shows that it is edema here around this because of the swelling. This is just the swelling around the site of bleed. Right. So when you do an MR angiogram CT angiogram in this child, you can just see, this is just for illustrative purposes for you to understand. So this shows that this is an artery, feeder artery, which widens into a nidus. So this what the big thing you see is the draining vein, so which takes the blood from here. So basically this area is where the bleed has happened. So the ruptured artery venous malformation can always be located with the CT angiogram. When you trace where the vessels are going and forming a convoluted draining vein, this is called the nidus, right? So having told this, you might have understood that not all bleeds are traumatic. So there can be non-traumatic causes also. This is an extreme case which I wanted to highlight. This is a story of a 4-month-old girl who presented with progressive lethargy and vomiting for 2 days, presented with seizures evolving into status, and had a very vague history of fever which was not present during the time of admission. She had raised intracranial tension, tense, bulging anterior fontanelle, posturing, intubated, multiple antiepileptics, and we all started antibiotics, fearing an infection. She also had a very vague history of unexplained symptoms. So you think of two conditions here. You think of a very vague infection, or you think of a metabolic disorder at this age with the presence of this particular history and the absence of fever, right? What we found on the CT was surprising. So you can see that this is a big infarct. You'll learn little later in the presentation that it corresponds to the internal carotid artery territory. So you can see that there is a huge infarct over the left hemisphere, and you can see that there is extradural, sorry, it's a subdural hemorrhage, which is concave, right? So there is a hemorrhage, there is a big infarct, which led us to consider a very ominous diagnosis. As expected, this child had a negative CRP and other infective parameters. The metabolic screen was all normal, but CSF showed frank blood, which was aspirated, and fundus showed retinal hemorrhages. So this patient is a case of shaken baby syndrome, or a non-accidental trauma, which we call. So most of these patients have skeletal abnormalities. If you do a skeletal survey or an infantogram, you can see that there are sutural diastasis. The sutures have been separated. You have a dislocation of the right shoulder. You can have many healed fractures with callus formation, both in the posterior part of the ribs as well as in this particular patient on the left side of the radius and ulna. So this is a very ominous diagnosis. If you don't know it, you won't suspect it. If you don't suspect, you won't find it out. Right? So always suspect non-accidental trauma when there isn't a neat fit to the diagnosis. If you don't think anything is fitting in, then you think of this, particularly in infants. Retinal hemorrhages are invariably present, and you look for multiple fractures. MRI or CT can show subdural hematomas, parenchymal shear injuries, and infarcts as shown in this patient. And you can have certain cutaneous findings which are called 4Bs: burns, bruises, bite marks, and tears of the frenula of the tongue in the mouth. So this is denoted by buccal. It may not be present in all cases, but you should know that these are real entities, right? Next, moving to hydrocephalus. So this image shows how a normal, the rightmost image shows how a normal CT scan looks like, how the ventricles should look like, right? And when you compare this, you can see that all the ventricles are dilated. The fourth ventricle, the third ventricle, the frontal horns, and the lateral or temporal horns of the lateral ventricles are dilated. And there is cerebral atrophy here. So this is just to compare the varying spectrum of findings. So this is due to hydrocephalus and this is due to atrophy. In both conditions, you can see the ventricles are dilated. In this image, you can see the lateral ventricles, temporal horn is dilated, but you see that the whole brain is shrunken. The sulci are very deep, right? Here you can see that there are barely any sulci which are visible. So this is how you differentiate hydrocephalus from cerebral atrophy. Both can have ventriculomegaly, which means that ventricles are large, but the reason for ventriculomegaly differs between both conditions. In this, there is increased pressure. In this, there is decreased brain matter. Hence, it is a ex vacuo dilation or a compensatory dilation of the ventricles. Now we classify hydrocephalus into communicating and non-communicating. We don't use obstructive anymore because most cases of hydrocephalus are due to obstruction somewhere. If the obstruction is extraventricular, for example, after a hemorrhage or meningitis, at the site of the arachnoid granulation, if there is obstruction, then it is called communicating because all ventricles, the lateral ventricles and the third and fourth ventricle communicate with each other. Whereas in intraventricular or non-communicating hydrocephalus, the site of obstruction is at the ventricular level. That is, within the ventricular system, there is an obstruction. For example, aqueductal stenosis or a third ventricular or fourth ventricular tumor which is obstructing. So this is called a non-communicating hydrocephalus, right? So I'll show you examples illustrative of both kind of hydrocephalus. So this is communicating hydrocephalus. You can see that all ventricles are dilated. You can see the fourth ventricle is dilated. You can see the third ventricle, which is generally slit-like, which is ovoid here. You can see the horns of the lateral ventricles also been dilated. This is due to post-meningitic hydrocephalus in a child. This is an example of non-communicating or intraventricular hydrocephalus. You can barely see the fourth ventricle visible anywhere here, only here it's barely visible. So this is basically due to the third ventricular tumor. You can see a midline tumor here. This is a non-contrast scan, so you cannot visualize the tumor, the margins of the tumor very well. But you can see that there is some calcification here, and you cannot see the third ventricle at all. Instead of the third ventricle, in the site of the third ventricle, the tumor is sitting, right? And the fourth ventricle is here, which is of the normal shape or slightly chinked in size. And this is because of the tumor of the third ventricle, which has obstructed and caused hydrocephalus. This hypodensity seen around the ventricle is called periventricular ooze. This is due to seepage of interstitial fluid from the ventricular, from inside the ventricles into the cerebral parenchyma, which leads to this kind of appearance. It means that the ventricle system is under pressure, and for the clinician, it means that the child has to be operated. That is a ventricular peritoneal shunt. CSF diversion has to be done as early as possible. I'll show you a few infections quickly before I finish. So you should know how meningeal enhancement looks like. So this is acute bacterial meningitis. I have shown a normal scan on the right side. This is a contrast enhanced MRI. So probably this is the first time we are showing a contrast scan. So you should know how a contrast CT looks like. So you can see that there is, the meninges are enhancing, and the meninges are enhancing very crudely or very irregularly and very thickly. And here you can see these vessels are enhancing, and there is very a little enhancement of the meninges properly. So this is normal, and the left shows meningeal enhancement due to bacterial meningitis. So what happens if bacterial meningitis complicates? So you know that one of the important complications of bacterial meningitis is a subdural empyema. So this picture shows subdural empyema. You can still see that the meninges are enhancing bilaterally, left more than the right, but more prominently you can see this meningeal margin which is enhancing, and you can see that there is a collection here. So this indicates this is acute subdural empyema secondary to bacterial meningitis, right? And another complication of bacterial meningitis is a brain abscess. So this is a non-contrast scan. You can see that the vessels are not enhancing, so it's a non-contrast scan, but you can make out this very big brain abscess. This is a very thin-walled brain abscess with not much of a midline shift, but there is edema here, right? But there is not much of a midline shift, though there is slight ventricular chinking on this side. So this is another complication of brain abscess, which you should be able to recognize on CT scan. You can see that the brain abscess is large and it is thin walled. These are the hallmark radiographic features. When you put a contrast inside, unfortunately I don't have the image, you can see that the ventricular, we will see that the ventricular lining enhances smoothly, right? So coming to viral infections from bacterial infections, you know that the most eminently treatable and the only probably treatable viral infection is HSV encephalitis. So you should know how herpes looks like on the CT scan. So whenever you have a hypodensity, I told you it could be edema or an infarct. These are the two important differential diagnoses. And if it follows a vascular territory, which I'll show you in the section on vascular problems recognized on CT later on, if it follows a vascular territory, you call it an infarct. If it doesn't follow a vascular territory, this is simply edema, right? So this does not follow a vascular territory. So it is edema, and you can see that the edema is localized to one side, that is the left side, and it is in the frontal lobe. Addition to that, the edema is causing pressure, so it is causing a midline shift. So the second plate is that of a contrast scan. So you can see that there is diffuse meningeal enhancement. In addition, there is a midline shift, that because the Fox cerebri is being pushed to the right side. This is confirmed by a CT scan which shows cortical and hyperintensity. This is a T2 scan which is showing cortical hyperintensity. So what is the virus which has a predilection for the frontotemporal lobe and causes refractory seizures, raised pressure, and encephalopathy? This is herpes encephalitis, right? So not all viral infections or not all infections are acute. There can be certain chronic infections. So an eminent example is congenital or intrauterine CMV. So in these patients, there is not much edema, rather there is shrinkage of the brain. This is atrophy, right? In addition to that, you can see there are fine periventricular calcification. So this is a case of intrauterine CMV or congenital CMV leading to microcephaly, developmental delay, persistent pneumonia, hepatitis. All these can be presentations of these patients in the newborn or the infantile period, right? So another infection which we think of when you consider calcifications on the brain is that of a child with a large head, and the diagnosis in that case would be congenital toxoplasmosis. These children have a predilection for developing hydrocephalus in the newborn period, and they can have very dirty diffuse calcification. When you compare to CMV produces a very punctate, beautiful kind of a regular kind of a picture of calcifications, whereas toxoplasmosis is described to produce a very thick and diffuse kind of a picture, dirty calcification. Along with a large head, hydrocephalus, you think of toxoplasmosis more than CMV, and both can have eye findings. You know that chorioretinitis is an eye manifestation, right? So again, this is another example of an infection which is neither acute nor chronic. So this is a subacute infection. These are the 4 cardinal signs of tubercular meningitis. So what are the cardinal signs? This is basilar meningitis or basal enhancement of the meninges in the base of the brain. This is around the cisterns of the brain where everything seems to enhance on the contrast CT. You can see that there is hydrocephalus in the second picture. All ventricles seem to be dilated, right? There are granulomas here. So these are tuberculomas, which is the third radiographic clinch point for diagnosis. And you can see that this part alone is hypodense. And this is following a vascular territory. This corresponds to the left middle cerebral arteries arterial distribution. So this is an infarct. So when you combine an infarct with granulomas, with hydrocephalus and basal meningitis, you would think of tubercular meningitis as the first possible diagnosis in our country, right? So the problem comes with very early stage tubercular meningitis. So in those patients, you cannot make a diagnosis, but the clue which I tell all my residents as well as people who ask me for it is that very early basilar enhancement can be seen here in the base of the brain, around the brainstem and in the cerebellum. So this is one clue. And the Sylvian fissure and the deep sulci, if you see, they can be subtle enhancement. So if an MRI is done, it can clinch it easier no more than this. But a CT scan for a trained eye, if you learn not to miss it, you can pick up these patients even before they develop the very florid signs of neurodeficits or vasculitis or strokes, as illustrated in the prior case. The prior case was a very late stage TB meningitis. This is an early stage TB meningitis, which is shown in this picture, right? You should know how a tuberculoma looks like. A tuberculoma is very large, right? It's a non-contrast CT. So in this particular case, when you give contrast, the whole lesion enhances. This is a contrast enhancing lesion with a lot of edema. Tuberculosis produces a lot of edema. This is a single lesion tuberculoma. Always when a radiologist encounters a tuberculoma or a clinician encounters a ring enhancing single lesion, he always thinks of another condition called neurocysticercosis. So this is neurocysticercosis, which shows a smaller lesion, lesser edema when compared to the tuberculoma, lesser midline shift. And the most diagnostic point here is the small dot which we see inside the lesion. This is the head of the worm, which is calcified, which is called the scolex. So this is the diagnostic feature. Of course, theoretically, you can have many differentiating points between NCC and tuberculoma, but I would say the only one point which you will have to look for in every patient is this mural nodule, which indicates a scolex. If a new scolex is there, then there is no point arguing whether it could be tuberculoma or any of the n number of lesions it can resemble, right? So I'll show you a few inflammatory disorders. So when there are multiple hypodensities, you always think of multiple ring enhancing lesions. So when there are no ring enhancing lesions, so it could be multiple tuberculomas, it could be multiple neurocysticercosis, but when you put contrast, you can see there are no enhancements. So what could this be like? This is a child who presented with acute afebrile encephalopathy after 1 to 2 weeks of a febrile illness. The child presents in deep encephalopathy to you. So this is clinically, you know that the diagnosis could be acute disseminated encephalomyelitis or ADEM. The CT scan, of course, as you know, is not helpful most patients. An MRI is essential for diagnosis, but you can suspect it on a CT scan when you see multiple hypodensities distributed throughout the white matter, sometimes involving the basal ganglia as well. Right. Another inflammatory condition which can be diagnosed on a CT based on a unique characteristic pattern is called acute necrotizing encephalopathy. So you can see that this is called the target sign, or the double halo sign, or the double donut sign. So you can see that the thalami, both sides are hypodense. As I told you, whatever hypodense could be edema, an infarct, it could be a cyst. In this case, it is neither of all this. It is what is the last one, that is necrosis, right? So this is necrosis. This necrosis can be very well confirmed when you do certain special scans on the MRI. That will be discussed probably in the next sessions. So this is secondarily due to a viral infection. It leads to devastating encephalopathy and has a very high fatality unless you treat it with very high dose steroids and all kinds of immunotherapy very early. Right. So this is, you can see also brainstem and cerebellar changes also here, but the diagnostic clinch point here is bilateral thalamic hypodensity on the CT. When you think of this, probably there is no second differential diagnosis for this condition. It is acute necrotizing encephalopathy. I'll just show you quickly a few tumors if I'm allowed to present for 5 more minutes. This is a posterior fossa tumor on the left side. It is a medulloblastoma. It is a very solid tumor, hence it is not very hyperdense. It is just isodense. You can see some calcification. There is no cystic changes. This is a non-contrast CT scan. Actually, both are non-contrast CT scan. This is a malignant tumor of the posterior fossa. It's very common in childhood, you know that. And there is hydrocephalus because of obstruction, and there is some periventricular ooze as well, which I had showed already. This is a benign tumor. As I showed you, it is not as hyperdense because there are less number of cells, because it is not malignant. So the the density also is lower. And you can see there is frank cystic region here also. So cyst with a mural nodule means in the posterior fossa, it is a pilocytic astrocytoma. It is a WHO grade 1 or 2 tumor. It has a good prognosis. Another tumor which is not uncommon in childhood is a brainstem glioma. So you can see that this is a very ill-defined, irregular, thick kind of a margin. For this, in this scan, this is a contrast enhanced scan. You can see that the brainstem is involved. So this again has a very bad prognosis because of its location, but it is one of the common tumors in the pediatric age group. You can see that most of these tumors don't have much edema. So that is one of the points to differentiate malignant lesion or a tumor from a non-malignant or infective or inflammatory lesion, tends to have more edema. One last tumor is craniopharyngioma. It's again a midline tumor. Children generally present with headaches, visual deficits, growth problems. They can have endocrine issues as well. So this shows calcification. The left, what I'm seeing now is a non-contrast CT, which shows peripheral ring-like calcification. If you can very carefully see, this is a popcorn-like appearance. You can see that there are small, honeycomb or popcorn-like appearance, very characteristic of craniopharyngioma. When you give contrast, it quickly fills. So it is again a contrast enhancing lesion, which is shown on the right side. So this is craniopharyngioma. I'll show you a certain vascular conditions before I conclude. So you should know how the vascular territory is distributed. So you can see that what is yellow corresponds to the middle cerebral artery, what is red corresponds to the anterior cerebral artery, and you know that middle and anterior cerebral artery are branches of the internal carotid artery, and the posterior cerebral artery is supplied by the vertebrobasilar circulation, which is again which is a different circulation altogether, right? So based on the hypodensities you see on CT, you classify whether which arterial territory is involved. So on the right, you can see, as I had already shown you in that case with tubercular meningitis, you can see that the MCA of the left side is involved. So this is a MCA stroke, right? When an MCA and ACA is involved, you know that the stroke is internal carotid artery stroke. I had already shown you, internal carotid artery stroke, because two of the branches are involved. So the stem of the artery should have been involved. So ICA is involved, right? This you had already seen in the child with non-accidental trauma, which had also shown a ICA stroke, but on the left side, now it is on the right side, right? How does a posterior circulation stroke look like? So you can see that on the left side of the image, if you carefully see, you can see a wedge-shaped infarct. So all arterial infarcts are generally wedge-shaped. You can see that the narrow, this is narrow in the center and wide when it approaches the cortex. It's very classical of strokes, arterial strokes. So you can see that the posterior cerebral artery territory is involved on the left side, but the right side is spared. And you can also see that one part of the cerebellum is also involved here, which respects the midline. So anything which respects the midline, which follows a wedge shape, which obeys, the rules of vascular anatomy, it means that it is a vascular kind of a hypodensity. So these are strokes due to the posterior circulation, right? When there are multiple territories, both anterior and posterior, you should suspect something sinister. There is a shower of emboli from the heart or some other place in the body, which is going and lodging in all arteries of the brain. So you can see that the posterior circulation is involved here as well as here. And you can see that there are anterior circulation changes as well. You can see here there are multiple wedge-shaped areas, and also the center of the brain is also involved. So there are multiple arterial territories which are involved. This is due to septic emboli, and this is an example of multiple territory stroke. Pediatricians should know one particular kind of stroke, which is called basal ganglia stroke, which is due to mineralizing angiopathy. So this is a very common condition which presents in toddlers. After very trivial trauma to the head, they suddenly wake up with weakness of one side of the body or dystonia of one side of the body. If you do a CT, you can see a hypodensity on one side of the basal ganglia. Sir, I'm finishing in 2 minutes. I'm just finishing. So when you do when you see such kind of a hypodensity, you always search for calcifications in the region of the basal ganglia. So this is because these calcified regions are those of the blood vessels which are calcified, which make them prone to shear stress. So whenever a child sustains a shear stress, whenever the child falls down or has a very trivial injury, the vessels get injured, and because of that a clot forms and there is vasospasm. Because of that there is an infarct. So this is a condition which has a very good prognosis. It does not need long time antiplatelet therapy, right? So these are venous infarcts. I'd like to conclude before finishing this. Do I have time or should I finish it now?
Two minutes more.
Yeah.
Please wind up with 2 minutes.
Yes, sir. I'll finish in 2 minutes. So these are venous infarcts. So you should not only think of arterial infarcts when you see when you think of or talk about infarcts. They can be venous infarcts as well. So what you can see here is a hypodensity in the temporal lobe on the left side. This is indicated by a red arrow mark. The important cleansing feature to differentiate an venous infarct from an arterial infarct is the presence of hemorrhage. So you know that the venous circulation has a slow flow, stagnant circulation. When there is a thrombus, there is always seepage of blood, right? So it is a wet infarct in pathology. So this presence of blood shows that it is a venous infarct. And you know that this is not an arterial territory. It's a very vague territory. It does not correspond to any known arterial territory. So whenever it is non-arterial in location and there is blood, you think of venous infarcts. So this is a plain CT which you can show that the thrombus can be visualized. So this is one of the BCCI which I told you. So clot is one of the C's. So just like blood, the clot also gets visualized. This is indicated by the blue arrow. This is just to show the temporal infarct in a cut which is higher than the left side cut, show that this is the temporal lobe infarct. And you can see that this is a superior sagittal sinus. This is called the delta sign, which is due to presence of thrombus in the superior sagittal sinus, and this shows as bright in a CT scan, which is plain. So this should not be bright, it should be dark. When it is bright, it means that the thrombus is sitting there, which is leading to the density, hyperdensity here. When you give a contrast, what happens? Contrast usually goes and occupies the dural sinuses. So when there is a clot inside, the contrast fails to fill. So it is seen as an empty spot or a flow void, which we call it. So this is called an empty delta sign. You can see that the delta has to be filled up in a contrast MRI. Just as opposite as you see in the non-contrast scan. In non-contrast scan, normally it should not fill. If it fills, it is a thrombus. In a contrast scan, it has to fill. If it does not fill, it is again a thrombus. It is just to confirm that what is sitting there in the confluence of sinuses, the superior sagittal sinus, is a thrombus, which is leading to the hyperdensity. One another condition, vascular condition, which can be recognized on the CT scan is a posterior reversible encephalopathy syndrome. It is commonly seen in patients with oncologic diseases as well as renal diseases with hypertension. It's a part of hypertensive encephalopathy. You can see that there are hypodensities in bilateral occipital regions. It does not strictly obey the vascular territory, right? And if you can see very carefully, that is why I put the MRI also here. It does not involve the cortex. It is primarily, say, a stroke or a vascular infarct should involve the cortex, right? If it does not involve the cortex, it means that there is white matter involvement. So anything involving the posterior white matter in this particular clinical constellation, this is nothing but posterior reversible encephalopathy, which is also called PRESS, right? But what if we have global hypoxia? I have discussed, focal hypoxia, ischemia in all these previous slides. But when there is global hypoxia, when there is less blood flow everywhere, this is a child with trauma and post-traumatic cardiac arrest. You can see that the whole brain is hypodense and the cerebellum is a little hyperdense. Normally, this does not happen. The cerebellum, and compared to the rest of the brain, is a little less in density. So when the reversal happens, it is called reversal sign, or the white cerebellum or the dense cerebellum sign. And in addition to this, to prove that it is trauma, you can see that there is a subdural hemorrhage on the left frontotemporal area as well, right? So this is the reversal sign. I'll finish with a few calcifications. These are the last 3-4 slides. So I've already shown you in the course of my presentation 2 important causes of brain calcifications on CT: intrauterine infections and mineralizing angiopathy. In addition to that, you should remember there are certain endocrine, neurocutaneous, and neurodegenerative disorders. So this is hypoparathyroidism. This was a girl with pseudo hypoparathyroidism, right? So she can have multiple thalamus, basal ganglia, as well as cerebellar calcifications. In severe cases, it can exist even in the cortical subcortical junction as well. So this is a very glaring sign which is seen in hypoparathyroidism, right? Another case of calcification is the Sturge-Weber syndrome. So Sturge-Weber syndrome, is due to a vascular malformation in the pia of the brain, pia mater of the brain. Corresponding to that, in the trigeminal or even the lower distributions of the of the fifth nerve, you can have these port vein stains, right? In addition to port vein stains, the MRI cleansing feature is the presence of pial angiomas, which lights up on the contrast enhanced MRI. If you do a plain MRI, you won't see anything. In due course, the slow flow in these venous malformations, what does it lead to? It leads to calcification in this area. So this is called tram track calcification. Of course, these are from different patients. You can see that the calcification is on the right side, whereas the pial angioma is on the left side. But it is just to show that this can be the MRI can show this very classical characteristic feature. I put this MRI, but the purpose of putting this slide is to show the tram track calcification, or the calcification of the cerebral gyri because of Sturge-Weber syndrome. So slow flow venous malformation. This is not something which you know already. This is something which you know already. Tuberous sclerosis. There are the 2 radiological findings, of which the calcification of subependymal nodules can be very classically seen. What you can see along the walls of the ventricles are the subependymal nodules, which are frequently calcified, which can be seen as black dots. So whatever seen on black in the MRI is usually calcification. In addition to this, you can see cortical tubers which are not seen on the CT. But in certain cases, in older patients, with time, these tubers get calcified. This is the CT of another patient on the rightmost corner, which shows calcifications of the cortical tubers as well. So this is again another condition where calcification can be picked up. So these are the skin findings. This is all something which you know already. your cutaneous angiofibromas, your ash leaf macules, your shagreen patch, and the forehead plaque. Right? There are certain neurodegenerative conditions. I'll just show you two before I conclude. So one is called cocaine syndrome, which can have a classical calcification on the CT. In addition to CT calcification, you can see that the cerebellum is low volume, that is cerebellar atrophy. So when there is calcification of the basal ganglia as well as rest of the brain with, you have a cerebellar atrophy, you think of cocaine syndrome. Again, they can have very characteristic faces resembling that of a bird. It's called a wizened appearance or a bird-like appearance of the face, right? So thanks for your attention. I thank the organizers for this opportunity. I take this opportunity to ask students to visit our YouTube channel. We run a very academic YouTube channel. We keep posting lectures and talks and shorts for students free of cost. So please do visit our channel, and thanks for the opportunity. Thank you.
Thank you, Dr. Kesavan, for a nice presentation. Arundhati?
Yes, sir. I'll be sharing my slides. Meanwhile, Shivan, you have 2 or 3 questions. So if you can answer them, that would be very nice. So I think if you have a look at your chat box, you'll be able to see them.
So
are my slides visible?
Yes.
Yes, ma'am. Visible.
Dr. Datta, please introduce Dr. Arundhati.
Yeah, I have already introduced. Again, I have introduced.
So,
Start.
Okay. Shall I start or wait for the queries to be answered or something like that?
No, you start
Please
and you write answers on the chat box.
Okay, so there has been a mild change in the schedule, and my lecture, which was supposed to be tomorrow, it has to be rescheduled today. So I will be speaking on infections and inflammations on MRI brain. But before that, I think it would have been great had the basic sequences of MRI been introduced to the house. But I'm afraid you will have to learn them tomorrow and then again go back to the presentation maybe. So infections and inflammation. So highlights of my presentation would be on bacterial infections, some of which has already been dealt with by the earlier speaker, in which I have covered the complications, that is a subdural empyema and brain abscesses, some of the common viral encephalitis, how do you identify them, what are the patterns that you are recognizing them, some of the chronic meningitis, what are the signs, and congenital infections, neuroinflammatory disorder, and ring-enhancing lesions, which always remain an enigma. So coming to starting the presentation with a case vignette. A 9-year-old child presented with intermittent high-grade fever for 5 days, 2 episodes of convulsion. CSF was suggestive of pyogenic meningitis. So the child was started on appropriate antibiotics. However, the irritability and persisted. The well-being did not return. And even after 7 days, suspecting a complication, an MRI brain with contrast enhancement was done. And here, lo and behold, what we found is, so this is a T1 weighted post-contrast image, axial image of the child. And here we find, as has already been pointed out, maybe that will help, that is, there is significant collection in the subdural space, which is enhancing, which has a white lining, as you can identify. So this is a contrast enhancing lesion, which is seen in the subdural space. So anything which enhances on contrast is believed to be inflammatory, can be infective. It is an active lesion because generally we give a contrast in the intravenous system. And if there is inflammation or there is infection and associated inflammation, there will be a separation of the perivascular spaces and exudation of those contrasts, leading to contrast enhancement. So this is actually what I want the residents to understand, the meaning of contrast enhancement, which actually suggests that there is infection or inflammation. So this is a subdural empyema, which had occurred as a complication, as a result of which this child had not improved appropriately with appropriate antibiotics. Next, coming to the next vignette. So a 5-year-old male child presented with low-grade fever and focal onset motor seizure. Previously, the child was developmentally normal. So when we have anything which is focal onset, there is always a chance of having anything abnormal on the MRI or the neuroimaging. So it is a dictum to do a neuroimaging. In this case, we did an MRI. So here what we found is that is there. These are, if I can go section by section. So this is actually a CT scan, and CT scan which is showing an axial view, which is a basifrontal view, and in which you can see a circumscribed lesion, hyperdensity, surrounded by a hypodensity, which is usually which is seen in the left temporal lobe. And this is a T1 post-contrast MRI again. So you can appreciate the contrast enhancement, which is seen along the lining and also along the wall of the lesion, which again suggests that this is a contrast enhancing, or it is an active lesion, which is actively inflamed, perhaps an inflammatory, or it is a infective lesion. Now, in order to further categorize, what we can do is we can go for diffusion sequences. And diffusion sequences, we have the diffusion axial sequence of the same lesion, and we have a negative image, which is called the ADC mapping, which again you will be taught in the subsequent sections. In diffusion sequences, there is stark and intense diffusion restriction of the lesion, which is suggestive of inflammatory or cytotoxic edema, and there is and the negative image shows a blackening of the brightness that we have observed in the diffusion. So this is again suggestive that this is true diffusion restriction, and this is not anything artifactual or T2 shine through, which we commonly call. So this is all suggestive of a pyemic abscess or a pyogenic abscess. So this is a ring. This is again a circumscribed lesion with inflammation, with infection, and having intense diffusion restriction, which is again suggestive of a pyogenic abscess. Now here we come to MRI. This is a flare section, which is axial, and there are several sections in which we can appreciate bilateral symmetrical white matter changes in the flare sections, and with hyperintensities, that is in the bilateral symmetrical sections, along with hypointensities, which are calcifications or calcifying leukoencephalopathy. This was the preliminary complaint in which the child had come with global developmental delay. We were suspecting some mitochondrial lesion, but then again, this child suffered severe infection, was obtunded, had to be intubated, and then we learned, and when we repeated the MRI, so these baseline changes were always there with the child, but when we repeated the MRI, we found that there was a well-circumscribed hyperintense lesion again in the left parieto-occipital region. And here, in the next section, if we appreciate the diffusion again, if we can compare the both diffusion, we will find that this is again a diffusion image showing diffusion restriction of the white matter along with a diffusion restriction of the circumscribed lesion. But here, if you remember the previous section, the diffusion restriction pattern is different. In this section, there is intense diffusion restriction, whereas in this section, there is peripheral diffusion restriction. So peripheral diffusion restriction is usually suggestive of a fungal abscess. So here, this child we diagnosed by fungal culture and also by the MRS that this turned out to be a fungal abscess, and the child was treated with antifungals for appropriate periods with the resolution of this lesion. Next, we come to another entity, which is chronic meningitis. So the common etiologies for chronic meningitis, we know everybody, it can be bacterial, it can be viral, it can be parasitic, it can be fungal, or it can be some other non-infective variants, which we are not dealing with in this session. So scenario 1 is a child having fever for 5 days, along with obtundation, neck rigidity, and what we find is this is a T2 axial sections on the MRI. And here, as you have been taught in the by the earlier speaker, that there is significant prominence of the extraaxial spaces with prominence of the ventricles as well. There is appreciable what we call as periventricular ooze. So there is dilatation of all the ventricles with periventricular ooze, possibly due to, and since all the ventricles are dilated, it is possibly extra, this is non-communicating hydrocephalus with periventricular ooze as the CSF is under pressure. So now, having done the contrast MRI, we find that there is increased enhancement of the basal area and also increase enhancement of the prepontine area. And that is very much suggestive in the scenario of subacute to chronic meningitis in our country. It is very much suggestive of tuberculosis, because, and with these subtle signs, we can always pick up TB even before it is too late, before it progresses to stage 2, that we can even pick it up in the prodromal stage. So this is again a diffusion weighted image. And here we see, I do not have the ADC mapping image of this patient. Here we see there is intense diffusion restriction, which is again suggestive of a subacute infarct, and which also suggests another manifestation of TB in the form of TB vasculopathy. So this turned out to be a case of TB meningitis with intense basal enhancement with hydrocephalus and with a subacute infarct formation. This is again a T1 post-contrast sagittal image, which is showing contrast enhancement. So again, I have in the next slides, I have dealt with what is normal contrast enhancement and what is abnormal contrast enhancement. So here you see that there is a thin white line, which if you can appreciate, and that is extending for more than 3 centimeters. And you can also see well circumscribed lesions, which are ring enhancing lesions, which have been observed in the sagittal section. So this is again a case of tuberculosis with tubercular meningitis, with tuberculomas in the basal area. So these are some of the sections. So subpile tuberculomas, brainstem tuberculomas, spinal tuberculomas, spinal arachnoiditis is what we observe in these sections. Next, coming to the role of neuroimaging in tuberculosis. So it is very important, especially as mentioned by the early speaker in the early stages, because if we are able to pick up early in the prodromal stage of tuberculosis, then we can prevent the neurological morbidity that may be seen in this situation. So basal enhancement, pre-contrast density and granuloma formation, along with hydrocephalus and infarcts, they are absolutely helpful in diagnosing tuberculosis. And the percentages are quite high of basal exudates. So in early scans, when we are suspecting tuberculosis, it is always advisable to do a contrast CT or a contrast MRI in order to appreciate the basal enhancement. And what do you mean by abnormal basal enhancement? As I have already said, that if it is a long segment, it is thickened, it is nodular, it is poorly demarcated, asymmetrical, and if then it is believed to be abnormal leptomeningeal enhancement, and it is not due to normal, and so we should always have our suspicion very high. So this is just a nutshell of the spectrum of CNS TB, which can be widespread, starting from tuberculous meningitis to other vasculopathy. Next, coming to another scenario in which where I would like to describe a 9-year-old child who presented with low-grade fever for 2 weeks and severe neck rigidity. And when we did a scan of the MRI, these are T2 axial section. This is a T2 axial section of the MRI, and this is a T1 post-contrast section. In T1 post-contrast, also we can appreciate some amount of basal enhancement and also prepontine enhancement, which is seen. And if we can, at first sight, the T2 axial section appears as if it is a normal scan, but if we look at it closely, we will find that the basal ganglia region, that is the caudate, the putamen, and the globus pallidus, appears to be a little bit untidy, and you find there are some foamy lesions. If you can, you just have to, observe your stretch of and stretch your imagination to observe that this is kind of appears like a soap bubble appearance. So here again, this is another image of the same pathology, in which this is again a T2 axial section, which is showing a soap bubble appearance, which is prototypical of cryptococcosis. And this is again a flare section, coronal section, which is showing the same area basal ganglia, in which there is hyperintensity, which has a variegated appearance and which is actually leading to pseudo, and this is actually the cryptococcal pseudo-gelatinous cyst, which is very commonly seen in the basal ganglia region. So imaging clues in cryptococcal meningitis, leptomeningeal enhancement may also be seen at the base. There can be hydrocephalus, there can be pseudocysts, cryptococcomas, in which they form ring-enhancing lesions, and spinal cord non-specific hyperintensities can also be appreciated. Next, coming to some of the two of the common congenital infections. So here, as already been mentioned, that there is one congenital infection in which they present with large head and diffuse calcification. So this is actually a CT scan in which you can appreciate that there are diffuse but fluffy calcification which are seen bilaterally in both the hemispheres, and calcification of flowing blood is always signal void. So this is a T2 axial section which is showing hypointensity, which is again corroborating with the calcifications. So this is a child presenting with congenital toxoplasmosis who presented with global developmental delay and microcephaly, however was treated and so had minimal neuromorbidity. Next, this is another scenario in which this is an MRI T2 axial section and a flare T2 and a T2 flare section, axial sections, showing bilateral symmetrical periventricular hyperintensities, and those hyperintensities are forming anterior temporal cyst. That this is the anterior temporal lobe, and you have cystic changes in the anterior temporal lobe. So this type of leukoencephalopathy, which is that is bilateral symmetrical white matter changes with anterior temporal cyst, is very much suggestive of congenital CMV infection. If we find such an MRI in a child having microcephaly, chorioretinitis, or presenting with hepatosplenomegaly and hearing loss, always think of congenital CMV. And if it is within the purview, then we can also have the child treated. Next, coming to some of the common viral encephalitis. So the MRI is again a very clinching factor, even though CT gives a clue, but the MRI actually clinches the diagnosis. So the MRI findings here is that you find this is again a T2 axial section, in which we find is that the right temporal lobe is almost atrophic. It is completely eaten away, and there is encephalomalacic changes. So temporal lobes are affected in 83%, insular region by 12%, the basifrontal area, white matter, and uncommonly thalamus, occipital lobe, and cerebellum may be involved. So what are we talking about? This is again another patient having basifrontal involvement, or also the peri-insular area or the perisylvian area involvement. And also, so this is, we are talking of herpes simplex encephalitis. Scenario 2 is we see an abnormal signal intensity in the thalamus, which is more on the right side. This is again a T2 axial, where there is significant enlargement of the extraction space, and also there is hyperintensity in the thalamus, which is seen in 80% cases. Also nigral involvement, substantial nigra of the midbrain is involved, in basal ganglia. And these children, they have a very poor course if not treated earlier, and if not having a mild presentation, they will present with severe dystonia, and this will lead to and so we should always, with this type of MRI, we should always suspect Japanese B encephalitis. Similarly, abnormal signal intensity is seen in dorsal pons, midbrain, medulla, and dentate nucleus. So you have this dorsal pons, you have the midbrain involvement, you have the periventricular involvement, and also the thalami involvement. And dentate nucleus of thalamus involvement, of the cerebellum involvement, is suggestive of, we have dentate nucleus of, is suggestive of EV virus, EV71, that is enteroviral 71 involvement. So this is again a summary of the MRI findings of the common encephalitic syndromes that we see. Here, herpes simplex has medial temporal lobe cingulate gyrus involvement and orbital surface of frontal lobe involvement. JAP-B always involves the thalamus, majority in 87 to 94%. Besides, nigral involvement and basal ganglia involvement is very common. And enteroviral involvement will have dorsal pons, medulla, dentate nucleus, cerebellum involvement. Next, coming to the neuroinflammatory diseases on the brain. So we start with a case vignette in which a 9-year-old female child presented with irritability, dimness of vision, right-sided hemiparesis, no history of fever, vomiting, or signs of raised ICP. So when we find, this is a flare section, which is showing the upwards 2 rows are the flare section, axial sections, and you can see asymmetric, large, fluffy, multifocal hyperintensities, and they are found usually in the white matter. And this is also appreciated as hypointensity, which is seen in the last 2 rows are the T1 axial sections. And here again, we can see multifocal hypointensity. So what can be the diagnosis? So yes, it is ADEM. And in the axial diffusion section, we can find in 30% cases, there can be diffusion restriction, and it is usually seen in the subcortical white matter, and that is where we find it. So this is a sagittal section, T2 sagittal, in which we see subcortical white matter hyperintensities, which are also observed. So this is again post-mumps, and this is a child with post-mumps encephalitis and ADEM, and in which we found this is first is a T2 axial section, next is a flare axial section, and this is also higher sections of flare in which we see the asymmetrical hyperintensities involving the white matter. So the black area is the white matter, and we find that there are white hyperintensities which are seen. Next. So this is one of the inflammatory lesions. One is the NMOSD lesions involve the dorsal midbrain, and you have the periependymal surface of the fourth ventricle, thalamus, the hypothalamus, large confluent. We have LETM, so I can always show you. So this NMOSD is a type of inflammatory disorder, ADEM, type of ADEM, in which we get the NMO antibody positive, and it is significant. Why? Because it is significant due to the prognostication, and here we see long segment myelitis, and we also see there is thickening and dilated and tortuous optic nerves, and also there is brightening of the optic nerves. Next, we come to MOG-associated demyelination. The specific areas of MOG-associated demyelination is there is involvement of deep gray matter. What do you mean by deep gray matter? The basal ganglia area, in which there are large, fluffy, poorly marginated lesions. They can affect the cerebellar peduncles, and also they can also have a confluent leukodystrophy type. So what are the red flags? The lesions that are perpendicular to the ventricles, they can serve as a red flag sign. So here, these are the features of NMOSD. As I have already said, that is involvement of periependymal areas and involvement of the juxtacortical areas. But if we have any red flag signs, what are they? These are long segment involvement of the corpus callosum. So this is a long corpus callosum, and you find there is a long segment involvement, whereas here it is along perpendicular to the corpus callosum, and also there are T1 black holes and patchy involvement. Then you should always suspect MS in pediatric age group, contrary to NMOSD. So next we come to another case vignette. So these are some of the atypical neuroinflammatory lesions. We have a 7-year-old boy, developmentally normal, presenting with acute febrile encephalopathy with renal dysfunction. The child became comatose, had features of raised ICP, had also sepsis and thrombocytopenia. And because of persistent encephalopathy, we went for neuroimaging. This was already shown in the CT scan, again repeating in the MRI. These are T1 sequences, these are T1 non-contrast axial sections, and we find that it is hypointense, especially the thalami are hypointense, and is showing a target sign which was observed in CT. So, which is showing again the diffusion sequence, which is again showing diffuse intense diffusion restriction. And this is the SWI sequence. This is a special sequence on MRI, in which we find calcification and bleed. So there are bleeds also. So what is this? This is another inflammatory lesion, which is called ANEC, or acute necrotizing encephalopathy of childhood, in which the prognosis is very poor. This child has to be treated very early with immunomodulation and with IVIG, methylprednisolone, and also tacrolimus. And tocilizumab has also been used, because if you do not treat early, then there is very poor prognosis. Similarly, we have another neuroradiological entity, which is called a clinico-radiological entity, in which a 3-year-old boy presented with low-grade fever and GTCS on day 1 of illness. He remained irritable and encephalopathic, and there was recurrence of seizures again on day 5 of illness. And when we checked the MRI, what we found, the routine MRI sequences were normal, but in diffusion sequences, we found that there was intense. This is the routine flare sequence. This is the routine T1 sequence. And however, the diffusion sequence and the ADC, that is a negative sequence, we found that there was intense diffusion restriction along the white matter, along with also the negative image showing a black matter, impression. And this entity is called acute encephalopathy with biphasic seizures and late diffusion restriction. This is again due to cytokine storm, has to be treated with immunotherapy and treated early in order to maintain or prevent the neuromorbidity. Next, coming to the last part of my talk on ring enhancing lesions, which always remains an enigma on the brain. So here, what we find is that is already it has been discussed that what is the difference between tuberculoma. So this is a T2 axial section, which is showing a non-caseating tuberculoma. So what is the appearance of a non-caseating tuberculoma? We will find that in a case of non-caseating tuberculoma, the core will be cystic, like NCC, whereas in a caseating tuberculoma, you have a rim which is hypointense and a core will be cystic. So this is the difference between a caseating and a non-caseating tuberculoma. This is just a contrast image, T1 post-contrast of the tuberculoma, in which we see in the basal area and also in the area of the midbrain, we find conglomerate lesions, which are thick-walled, larger, multiple, and hence suggestive of tuberculoma. Similarly, we come to the next case scenario in which this is a T1 post-contrast, and if you can appreciate that there are two lesions. One lesion is here, which is again contrast enhancing. And if we see the T2 axial images, we will find that the core is hyper intense and there is perilesional edema, which is described as white, and there are two lesions. So if the core is hyper intense and the child presents with seizure, and we find that is suppressed on flare, then we should always suspect NCC. So this is just a differentiating point in which we find that NCC in T2 weighted image is T2 is always hyper intense, whereas in tuberculoma, unless it is like non-caseating tuberculoma, will be hyper intense. However, caseating tuberculoma, which is normally seen clinically, will be hypointense with a rim of hyperintensity, as shown before. And this is just another picture to give you the effect of a starry sky appearance. And this is a T2 flare, and this is a flare in which showing multiple lesions. And if you can zoom and if you can appreciate that there are some scolex, which is also appreciated in this. So this is a case of multiple disseminated NCC, which we had in our clinical practice. And we can also think something beyond ring enhancing lesions, that is tuberculoma and NCC. So this was a child who presented with altered sensorium and hemiparesis, and we found what we found on T2 axial sections is that there was a expansion of the pons and on which enhanced on contrast, and this was actually what turned out to be, this is again a flare section and which is showing an expansion, and that enhanced beautifully with contrast. And so this actually turned out to be a glioblastoma multiforme. So ring enhancing lesions can have a long list of differential diagnoses which the residents have to know. The cerebral abscesses, which have been shown earlier, also forms. You have tuberculomas, you have neurocysticercosis, you have metastasis, glioblastoma multiforme, even demyelination. If it is tumefactive or demyelination, the subacute stage can also have an incomplete shrink. Therefore, to sum up, this has to be your approach in reading an MRI, especially in infections and inflammatory in lesions, have to be systematic, prudent, and meticulous, and let not those zigzag lines, black and white, disturb you and dazzle your eyes. Instead, if you can read them systematically, then they will help you to come to a diagnosis and treat your patients in an appropriate manner. With that, I would like to end my session and thank you all those who have been associated, all the patients and the clinical material and the institutes where I worked, both past and present. Thank you.
Thank you, Arundhati, for your nice presentation. So I think our next speaker is Dr. Dipankar Das. So Dr. Das is the professor of radiology in Institute of Child Health, Kolkata. So it's over to you, Dr. Das. Please share your screen. Seeing after a long time. He will speak on malformation on MRI brain. Dipankar, please make it for a year.
Yeah, can you hear me?
Yeah.
Perfect. Can you see me?
Yeah. Perfect.
Dr. Roy?
Please proceed.
Yes, you're seeing me after a long time. I know. So, very good evening to everybody. From the last presentation, what I learned that the best images are from my equipment. So that was really rewarding for me. So my topic of discussion today is on brain malformations, which is an endless big topic. But we have to summarize these things in 20 odd minutes like that. So the first thing is why does these things happen is mostly unknown. As you can see from the slide that it is about 60%. But the known factors like maternal diabetes, infections like torch and other viral infections are also important. And another important thing are drugs, especially anti-epileptics commonly used, and abusing drugs like alcohol, cocaine, etc. So these things can produce teratogenicity and abnormal brain malformation along with malformation of other parts of the body. Some are genetic, as you can see here, autosomal or X-linked or due to some mutation. So if you go back to the embryology of brain development, which happens very early in the embryonic life, first thing is the neural plate, which folds into a neural tube. And this, from the rostral end, 3 primary brain vesicles develop: prosencephalon, mesencephalon, and rhombencephalon. Those 3 parts of the brain are developed from the brain vesicles. And around the ventricles, the germinal matrix, which actually give rise to this glial cells and neuronal cells, which later migrate towards the periphery from the central ventricular part, happens. So during neuronal proliferation from the germinal matrix zone, there happens a few things which produces glial cells and which drag subsequently the neurons to the peripheral cortex. This process is called neuronal migration. Later on, that organizes into layers to form the stage of organization or cortical development. And subsequently, the white matter myelinates, and that ends the development of the brain. So this is in short, and often we get some disorders related to this neuronal migration. This germinal matrix, you can see 7th week it migrates. So I'm not going into the details of these genetic things like LIS1, DCX, filamin, merosin. These are common genes which are incriminated for this process, and defective genetic consequence of these things can give rise to malformations. So if we approach the thing clinically, apart from the textbook teaching of the classification system, what we come across clinically, usually the children come with larger head or with smaller microcephaly. As you can see here from the craniofacial disproportion, the first one is a macrocephaly, the second one is the microcephaly. You can see some cleft, facial cleft here, and here there is asymmetric face. Here some swelling is there. Here some staining is there. This type of children usually come to us, especially in Institute of Child Health. So how do we proceed? So we have to make up something, and first we have to know the normal things which happens, like benign enlargement of the subarachnoid spaces. This is actually a normal phenomenon because of the immaturity of the arachnoid villi, which are responsible for the absorption of the CSF. So rapid cranial enlargement, usually between 2 to 7 months of age, without any other neurological abnormality, should not be a point of concern. But often it is a point of concern for the parents, so they come to us. But we have to follow up if there is no neurological abnormality. Where if what we found in MRI, this one is, you can see the large subarachnoid spaces and mild dilatation of the ventricles. These 2 things are there, and you should rule out any parenchymal lesion. Then this is all, you can see that all is CSF. This is a very old picture of mine when I used to do CT scan also. So you can see the whole black things, these are CSF, and this child is having a large head, hydranencephaly. Thin cortical mantle you can see around the dilated ventricles, or CSF filled cranial cavity you can see. So this is not compatible with life. Another important and common thing is Dandy-Walker malformation. The classic Dandy-Walker malformation is like this, where there is hypoplastic cerebellum, there is elevation of the tentorium with a large posterior fossa cystic malformation.
You can use the cursor or the arrow.
Okay, so this is the cerebellum, and this is the posterior fossa cyst, which is actually communicating with the fourth ventricle, and the fourth ventricle is not otherwise delineated. So that means the cyst is the fourth ventricle. This is the classical Dandy-Walker malformation, which was originally described. But later on, it was found that there are many variations. There is minor variations like the lower one, where you can see the enlarged cisterna magna, which is communicating with the dilated fourth ventricle. So this type of things are also the variants, and they are grouped together as the posterior fossa cystic malformation. But whenever you get this type of Dandy-Walker malformation, you must look for the supratentorial anomalies like heterotopic gray matter or dysplastic corpus callosum, etc. So next cause of large head or this hydrocephalus is due to aqueductal stenosis. So this is the cerebral aqueduct, where you can see a thin membrane-like thing, which is obstructing the CSF flow from third ventricle to fourth ventricle. Often this type of things are not seen. Only there is narrowing or obliteration of this space of aqueduct, or you may get increased flow, which gives rise to flow voids or hypointense things on titulated images. So these things you have to see in this region of aqueduct, and classically the fourth ventricle is not dilated as the lateral and third ventricles are. So that gives rise to the clue of aqueductal stenosis. So this is a very old case of myself. This is vein of Galen malformation. Is a contrast CT scan. This contrast CT scan showing this is enhancing dilated vascular structure in the midline posteriorly, which is called vein of Galen malformation, which was previously actually it was called as vein of Galen malformation, but here actually the vein of Galen is not formed. So the proper terminology is median prosencephalic vein malformation, because this is the precursor vein of Galen. So this is the thing which is shown nicely on MR angiography. So this is the dilated median prosencephalic vein, which in normal course give rise to vein of Galen. So this can also produce hydrocephalus and large head. Another cause of large head are Chiari malformation. Chiari malformation, classically Chiari 1, 2, and 3. There are other classification systems also. But classically, what happens in the Chiari 1 malformation, there is cerebellar tonsillar descent, more than 5 millimeter is significant. And moreover, you have to look for the crowding here in the area of foramen magnum. Here you can see the crowding. So this is the line of foramen magnum. So this is definitely more than 5 millimeter. And there is crowding, which is giving rise to hindrance to the CSF flow. And another additional finding here is the syrinx formation in the cervical cord. This also you should not miss. And this is the ballooning of the corpus callosum and dilated ventricular system. But Chiari 1 malformation may not be associated with dilatation of the ventricles. And this crowding often gives rise to other types of symptoms like headache, vertigo, or lower cranial nerve pulses like that. So this is often it is difficult to diagnose clinically, this Chiari 1 malformation. But on MR, we can see there is crowding in the foramen magnum and there is cerebellar tonsillar descent. And in Chiari 2 malformation, along with cerebellar tonsillar descent, you get herniation of brainstem also. Part of the medulla is down. Here you can see this is the level of foramen magnum. So not only the cerebellum, a part of brainstem is also herniating caudally. So that is giving rise to hindrance. And there is dilatation of the ventricular system, and it is almost always associated with meningomyelocele. So it is very easy to diagnose. And the rarest one is CRE3 malformation, where there is not only a gap in the occipital region, there is absence of posterior elements of the upper cervical vertebrae. So there is herniation of the posterior fossa contents, mainly the CSF and dysplastic cerebellar tissue outside. This is an extremely rare malformation. In last 17, 18 years, I have got only 1 or 2 CRE3 malformation. This is extremely rare. You can see that there is absence of upper part of the cervical posterior elements. And these are neurocutaneous syndromes. I will not go into the details of this because I think tomorrow there is another session on this. But this is a Stargardt syndrome. These are all malformations of brain associated with other cutaneous disorders like this. In the same trigeminal area, you can see atrophy of the brain, and there are some encephalomyelitic changes in the white matter, calvarial thickening. And if you see on contrast MRI, this is another different patient. You can see gyral enhancement. These are basically due to the capillary angiomatosis over the cortical surface, which give rise to this type of enhancement. And in the CT scan, you can see this is a railroad or a tram track like calcification classically, and along with hemiatrophy. So this is a patient with neurofibromatosis where there is sphenoid wing dysplasia here, and there is some protrusion of the eyeball, proptosis. So these are the things in neurofibromatosis. You get also the brain changes. This is type 2, where there is bilateral acoustic schwannoma. This is a hallmark of neurofibromatosis type 2. And the next one is tuberous sclerosis, where you get this type of Ashleaf macules or white hypopigmented macules, very classical. This is a very old image of myself when I used to do in permanent magnet 10, 15 years back. So these are the subependymal nodules, and these are the cortical tubers, subcortical tubers. So in the newer equipment, see the quality of image has changed. So these are the subependymal nodules, and these are the subcortical tubers, which are appearing hyperintense on T2-weighted images. So I showed in the next type of images are midline defects. So there may be some midline cleft in the lip and palate, but there may not be apparent outside, and only the inner things, that means inside the cranial cavity, there are defects in the midline like corpus callosal dysgenesis, absence of septum pellucidum, septoptic dysplasia, and spectrum of holoprosencephaly, which often is associated with midline, exactly in the midline, cleft lip and cleft palate. And along with that, pituitary gland abnormalities, which is another midline structure. So this is what this is. Dysgenesis of corpus callosum is very easy to diagnose because the lateral ventricles are lying parallel to each other. And you see in the sagittal images, there is no corpus callosum, an absence of cingulate gyrus, and only a remnant of the rostral part or genu is present. So this is dysgenesis of corpus callosum, and oftentimes it is associated with two things. One is cyst. Here you see the midline cyst along with the corpus callosum dysgenesis. So in the region of corpus callosum, there is cystic malformation. There are type 1, type 2, and other things. I'm not going into the details. And the next thing is lipoma, midline lipoma in the region of corpus callosum. So this hyperintensity on the T1 weighted images, this one is the lipoma. So basically the dysgenetic corpus callosum is associated with this fatty tissue. And the next day, this is our recent images. So you can see the difference in the image quality. So this is, you can see that pituitary fossa is almost empty. And you can see a small pituitary gland and a bright spot here. This is actually the posterior pituitary bright spot, which is seen on T1 weighted images, not T2. Posterior pituitary bright spot is a normal thing that is seen on T1 weighted images. You can see instead of located here, it is located in the hypothalamic region, in the infundibular region. That means it is in the ectopic location. And see, there is no stalk. The pituitary stalk is absent. So this is called stalk interruption with ectopic posterior pituitary gland. This is an NTT. So this is also a midline lesion. So these are the different types of holoprosencephaly. See the median cleft. Usually it is in the paramedian location in other clefts. So here there is fusion of two hemispheres and fusion of the lateral ventricles. There is no septum pellucidum. This anterior interhemispheric fissure is absent. The posterior one is visualized. This is the ultrasound image. These are very old images of myself. And there are three types, lobar, allobar, and semi-lobar types, depending on grades of fusion and degrees of separation. These things are there. And this is the dilated ventricular system. And you see this thalamic fusion is there. So this is another case of holoprosencephaly. This is one condition where the corpus callosal anterior part is not developed, but the posterior part is developed. In general, when there is dysgenesis of corpus callosum, there is a dysgenesis in the posterior part, and the anterior part is usually developed. That is because the corpus callosum develops from anterior to posterior. So if there is any interruption in the process, there is dysplasia of the corpus callosum and it is affecting the posterior part. But this is only one example, is holoprosencephaly associated callosal dysgenesis, where the posterior part is developed, but the anterior part is not. This is one difference. So this is a very old patient, Zubat syndrome. First Zubat syndrome I came across around 15, 16 years back. So this is the classical molar tooth. This was in the newborn period, presented with nystagmus. This was later reported in our Journal of Indian Medical Association. So this was the publication of ours. And later on, we found a lot of molar tooth malformation. Here you can see the cusp of the molar tooths, a classical molar tooth appearance. And these are the superior cerebellar peduncles, which actually give rise to the cusps. So this is another very rare type of dysplasia. This is called dorsal tegmental cap dysplasia. This is in the pontine region. You can see there is a wedge-like protrusion here. So this is the tegmental cap, which is dysplastic. This gives rise to cranial nerve palsy. And this is relatively common thing is hypothalamic hamartoma. Here you can see the gray matter intensity lesion here. This one. So this one, one should scrutinize always carefully, because pituitary gland stalk, this is the mammillary, and these are the optic nerves and chiasma crossing. So in this region there is a crowding normally. So you must see any extra structure is there or not. So if any extra structure, you scrutinize whether it is like gray matter intensity and it is non-enhancing. So this is called hypothalamic hamartoma. They usually present with precocious puberty or with gelastic seizure. So other malformations which give rise to epilepsy syndromes are like this: hemimegalencephaly, focal cortical dysplasia, and this cortical organization defects like lysencephaly, heterotropy, etc. I'm discussing in the subsequent part. But before that, just have a look of arteriovenous malformation. This is also a brain malformation. You can see the blood products are there and vascular flow voids. And these are SWI images showing the blooming, typical blooming of blood products or hemoglobin degradation products. So this is the vascular malformation. You will get a prominent draining vein, and here is a nidus. So this is the arteriovenous malformation or AVM. And another thing is cavernoma, which is different. There is not arterial component. This is a slow flow malformation, venous malformation, where you get bleed in different stages. Sorry. So this is called cavernoma. This is a common thing. Often because of bleed, there is perifocal edema and give rise to seizure or focal neurological deficits, etc. So coming to microcephaly, as opposed to the large head, is simplified gyral pattern. one should not make mistake this from the package area, because in package area there is thickening of the cortex. But in microcephaly, it's simplified gyral pattern. Only the sulcation is reduced, but the cortical thickness is preserved. So this is package area, this one, and this is the simplified gyral pattern. See, this is the cortex. This thin hypointense, relatively hypointense is the cortex. But here, the cortex is from here to here. And this black one is the myelinated white matter. So this is package area because the cortical thickening is there. So this is another patient with package area, you can see. And package area, lysencephaly, they're together called agiria pachygyria complex. So another cause of epilepsy is focal cortical dysplasia. This is a SPECT image showing a subtle cortical dysplasia here, where a subcortical hyperintensity is there, and this is the overlying dysplastic cortex. You can see this is the area. At times there is hypermyelination and there is darkening of the cortex on T2 weighted images underlying the dysplastic cortex. So this is another type. And this is a classical type of cortical dysplasia where there is cortical thickening and subcortical hyperintensities on T2 weighted images. And there is prominent sulcus. Bottom of sulcus sign, this is called. So this is a classical cortical dysplasia. This is a T2 weighted and flare, you can see it better. Here also there is a focal cortical dysplasia here. FCD may be associated with calcification. Say here on CT scan, you can see this calcification, but you can't really appreciate the cortical dysplasia here. But on SWI, you can see the calcification here, and this is the dysplastic cortex corresponding to this area. So this is the cortical thickening. Here also you can appreciate this is the cortical thickening. You can compare with the opposite side, and calcification is associated. This is a large dysplastic cortex. Nobody will miss this lesion, and there is deformity of the ventricles and dilatation. Like cerebral cortical dysplasia, there may be cerebellar cortical dysplasia. That usually takes the shape of an abnormal cleft. So here you see asymmetric cleft on the left side of the cerebellar hemisphere. So this is an area of cerebellar cortical dysplasia. So I'm showing another example, like cleft is here, and this is a dysplastic cerebellar cortex. Here also you can see. So this is from our older machine, and this is from the latest 3 Tesla machine. See the difference in gray white matter differentiation and cerebellar folial pattern, you can appreciate better. So these are classical torch infection as Dr. Arundhati has just described. So these are the areas of white matter abnormalities. Along with that, there are package area. That means thickening of cortex and reduced sulcation and dilatation of the ventricles. This was a known case of torch, and you can see periventricular and cerebellar calcifications here also. So this is another patient with polymicrogyria. Here you can see the gray-white junction is undulated or irregular. And along with that, there are white matter signal changes. This is in our country commonly due to torch infection. Another example of polymicrogyria, if you compare this cortex with the normal cortex, on T2 weighted images in case of infants, you will get the answer. On T1 weighted images, it is less well seen below the age of 1 year because the white matter is not myelinated. This is another example of polymicrogyria. This is a classical polymicrogyric cortex. You can see this undulated gray matter. This is a heterotopic gray matter. This is a neuronal migration defect. That means from the germinal matrix to the cortex, it has not moved properly. So there is a area of dysplastic gray matter, which is called heterotopic gray matter. There are 3 types: subcortical, subependymal, and band type. So this is this one is subcortical and this is subependymal. You can see the undulated margin of the ventricles, and these are the subependymal heterotopic gray matter here also. And often this subependymal heterotopic gray matter, which can act as a seizure focus, are very subtle, very small. So one has to scrutiny very carefully. As this is a nodular gray matter on T1 weighted images, but this is large areas of subcortical heterotopic gray matter. This is called transmantle heterotopia. Transmantle means it is extending from the cortex to the ventricles. This is the area, transmantle heterotopia. And this is band heterotopia. Anybody can appreciate is this. This is the gray matter, this is white matter, and this is the cortex, and this is the subcortical unmyelinated white matter. So 1, 2, 3, 4, 4 layers. And this is the abnormal gray matter band, which you can appreciate here on T1 weighted images better. Here you can see it much better. This is the band of abnormal gray matter, this one. Lysencephaly, all of you have seen probably. There is absolutely no sulci, and this hourglass type of deformity of the Sylvian fissures. This is very classical of lysencephaly. This is hemimegalencephaly, because on one side, the right side, the cerebral hemisphere is larger, and this periventricular region shows abnormal white matter signal intensity. There is cortical thickening and indistinct gray white junction. So these are the signs of polymicrogyria and white matter signal abnormality, along with a asymmetric enlargement of right cerebral hemisphere. So this is called hemimegalencephaly. This can give rise to intractable seizure. This is another example. Schizencephaly, all of you know, closed lip and open lip, two types are there. This is an open lip schizencephaly. So this is large CSF clefts. This is on CT scan, very old companion of myself. So large head. And this is a closed lip schizencephaly. See, this cleft is closed and extending from the cortex to the ventricular surface. This is a characteristic feature of schizencephaly, that the cleft extends up to the ventricular surface. So these are bilateral. This is another bilateral open lip type of schizencephaly. So these are the open large CSF clefts communicating with the ventricles. This is a thing with intracranial dermoid. All of you can appreciate because they're a mixture of tissues. You can see calcific components. This is a CT scan. So these are calcific components. This is ventricle, little dilated. And this is another very common thing is arachnoid cyst. And this is a classical location in the left anterior temporal region. But arachnoid cyst often poses difficulty in diagnosis when it is intraventricular like this. This is in the region of third ventricle and giving rise to hydrocephalus. You can see this is the arachnoid cyst and these are the dilated lateral ventricles. So this is another intraventricular arachnoid cyst. So how to differentiate arachnoid cyst from epidermoid? Because epidermoid also give rise to CSF intensity lesion. The best way to differentiate is flare and diffusion weighted images. On diffusion weighted images, epidermoid is bright, but on arachnoid cyst doesn't show any diffusion restriction, so it will never be bright. On flare images also, epidermoid is hyperintense compared to the CSF. So the next midline, the next defect is Kalman syndrome, which is related to the olfactory bulb. This is another malformation, which is actually a neuronal migration defect. This from this olfactory bulb, these are the normal olfactory bulbs. You can see symmetrical, and there are two xyri. One is called medial orbital gyrus, and another is called gyrus rectus. So these two gyri you must follow. You can see it better here. So this gyrus rectus and medial orbital gyrus, and this is called olfactory sulcus. So depth of the olfactory sulcus is also important. And this is the olfactory tracts and bulb. These two things are in cross section. But here you can see these two gyri are not formed separately. They are fused. Here also, here also they are fused. And you don't see the olfactory bulb and tract. So often it is associated with anosmia and hypogonadotropic hypogonadism, which is collectively called Kalman syndrome. So the first one is Kalman syndrome. We had a publication on 2016 in a Sri Lankan journal. So we had got many Kalman syndrome came across. So this is just for recapitulation. You can see this another hypothalamic hamartoma. And this is another teaching is that whenever you don't get things in the cranial cavity that can explain the clinical scenario, you must see the cervical cord and the cradiovertebral junction. As in this patient, you see there is the prominent opistheon, that is the posterior lip of the foramen magnum, which is prominent. This is a child with achondroplasia. And see, this is impinging the cervicomedullary junction and giving rise to myelopathy. So the weakness of the limbs are not really due to this cranial causes. This is because of the cervicomedullary junction lesion. And usually the ventricles are a little dilated, so the attention goes to that. But you must see the foramen magnum and this area and the cervical cord as far as visualized. That's the model. So thanks for your attention. So I conclude here. We had a lot of things, but for constraint of time, we can't discuss more about this topic. Okay, thanks.
Thank
all.
you, Dr. Das, for an elaborate presentation. So, do we have any question? I think nothing. You have taught so well, there is no question. But if there are some questions in our group, please answer those. So, over to you, Arundhati.
I would like to request the participants to, type the questions for our esteemed faculties to answer. It can be like everybody can type whatever questions. So they had a grievance that they were not able to comprehend because the basic talk was missing actually because of some constraints. We had to reschedule the talks and then they did not actually learn, if we go step by step, the sections of the MRI. So anyhow, that the only thing that can be done is maybe they can come back to the recorded version, I suppose. So I think it will be available. And then maybe after tomorrow's talk on the basic MRI, they can then come back again and see the talk. And then maybe if they have...
please ask Dr. Gupta to stop sharing.
Yes.
Dipankar, please stop sharing. Go ahead. Stop sharing. Yes.
Okay.
Yes.
Yes,
So,
yes.
yes. So, like they had this grievance that maybe they did not learn the basic sequences, but then we had to reschedule because of logistic purposes today. So maybe if they can come back and see the recorded version after seeing tomorrow's talk on basic sequences, then they will be a lot wiser, I think, because I think the talks were pretty lucid. Sir had a wonderful talk and we all tried. Let's see if it really helps. So with that, I think we come to the end of today's session. If there are no other questions to be answered, so ma'am, can we thank all the faculties and thank ma'am, that is Professor Kalpana Datta, who is the IIP President of West Bengal IIP branch, and also we have Dr. Shapun Rai sir, who is our scientific chairperson of the, and also we have the esteemed faculties, Dr. Dipankar Das and all the other faculties. I would like to thank them for their valuable time and presence, and also to make this workshop a grand success. Hope we are able to cater to the needs of the participants and they actually learn a lot from the workshop. Hope we that. And with that, I would like to sign off and thank everybody. Thank you.
Please join tomorrow at the same time,
yes.
6 p.m. sharp.
Mm-hmm.
Dipankar, bye-bye.
Okay.
Bye. Good night.
Bye. Good night, everybody.
Thank you. Thank you. It's a wonderful session. And in one day, you won't learn the whole neurology. I'll rather say that to all the delegates and participants, you will learn a bit and bit. So you have to make a practice and listen the the YouTube channel, which is there in our these programs. All are available in YouTube channel. I think you go through it, then only you will learn a bit and bit. Then you will be an expert, I think. So and you will always have an opportunity to ask the questions in the WhatsApp group. go on asking the questions in WhatsApp group, whatever the possible, without having any visual impression. They can explain, all the experts can explain the things. And tomorrow we must join. There are more exciting things are waiting. And we have learned a lot from all the learned speakers. I must thank Dr. Arundhati, Dr. Shapun Rai, Dr.